Good afternoon, good morning, and good evening to everyone. We have over 500 people have registered for the second Innovation Forum in the WHO Western Pacific region under the title Scaling for Impact. We welcome everyone here in our conference room in Manila, in the Zoom meeting, as well as in the live stream on YouTube. Welcome to this second adventure and journey into the area of health innovation in our region. Innovation is an operational shift for the future. For the future is the WHO WIPRO policy on becoming the healthiest and safest region in WHO. And as we go on this journey, it is clear that business as usual will not cut it. We have to be creative, we have to find new solutions. But as we shall see on this journey of these 2 days, it is not enough to have great ideas. It is extremely important to ensure that we have to find ways of scaling and achieving population health impact. In this first day, we shall be looking at the winners of the Innovation Challenge and looking at the process of problem solving. Over the last months, since last September, we have been calling globally, but with an emphasis on our region, we have been calling out for innovations and innovators and innovative solutions that can make a difference in the lives of people in the WHO Western Pacific region. We have had over 400 applicants, 150 shortlisted, and today we shall be awarding 29 of the winners. We thank all who have taken the trouble to join, and we will look forward to awarding the winners of the first Innovation Challenge. Tomorrow, in our second day of the forum, we shall be looking at the challenge of the entrepreneurial state, of how do we make the member states of the Western Pacific innovative? How do we ensure and support and facilitate that innovation becomes part of the DNA of population health in the Western Pacific? So with these two themes, celebrating innovation and the innovators today, and looking at how member states can become entrepreneurial and institutionalize innovation, we hope to look at two facets of the theme of scaling for impact. But enough from me. I introduce myself as Gordon Galia, the WHO representative in China, but also the strategic lead for innovation in the Western Pacific region. I hand over to our regional director, Dr. Takeshi Kasai, for his opening statement.
Honorable Ministers, distinguished partners, ladies and gentlemen. Greetings from Manila, and thank you for joining our second Innovation Forum in the Western Pacific region under this year's theme, Scaling for Impact. The Western Pacific region, home to more than 1.9 billion people, is faced with increasing health challenges making business as usual no longer an option. In our regional vision for the future, we have adopted a collective mission of becoming an even healthier and safer region. This requires WHO and member states to seek new approaches through innovation. The COVID-19 pandemic makes this need even more urgent. Therefore, we must reprioritize our public health issues, reoptimize systems, and continue to develop creative ways of doing things. At our first forum in 2020, we crafted a vision for innovations in the Western Pacific. And today, we have gathered to take that vision into action. In this forum, we ask, how are member states and stakeholders innovating for the future of public health in this region? What can we do together to systematically and broadly harness the innovations benefiting our populations? On the first day, the winners of the WHO Western Pacific Innovation Challenge will share their perspective of tackling the most pressing health challenges in the region. And on the second day, we will ask member states, how do they imagine the intersection of economics and health for all? What ways can we find to strengthen national health system by institutionalizing innovations? And finally, we will also ask what WHO can do to support the governments on this journey. I'm pleased to congratulate the first WHO Western Pacific Region Innovation Challenge winners, selected from over 400 participants by 2 panels of judges comprised of WHO staff and industry experts. I hope you stay connected with us and share your vision, passion, knowledge, and experience in understanding and tackling these challenges. Thank you very much, and I wish you a productive forum.
Thank you, Regional Director, for those rousing words. And now I ask the technical team to queue up the video that we shall use to acknowledge the winners of the WHO Western Pacific Innovation Challenge for 2022. Congratulations to each of these hardworking innovators, academics, entrepreneurs from around the region. We have 29 winners, each of whom will introduce themselves in 30 seconds on the video that we shall now be releasing.
The International Pandemic Preparedness Center, or IPPC, is a single unified real-time infectious disease surveillance platform that deals with disease control from end to end. The scope of IPPC aims to cover infectious diseases, antimicrobial resistance, and biothreats. And it does it with 4 components: the Central Intelligence Platform, which functions as a registry and a consulting platform for public health emergencies; the Rapid Research Response, or R3, that facilitates rapid scientific publications and outbreak response; IPPC-FX, which looks at fund mobilization, especially for the lower middle income countries; and the heartbeat of it all, the Power Lens, which is an AI-driven predictive and prescriptive analytics component of IPPC.
There are thousands of waterless upland villages in the world where people need to fetch water over high elevations and long distances, resulting in only around 40 liters per day per household. This shortage creates many challenges in terms of health and sanitation and other activities in and around the houses. The 8V ram pump brings an increased volume of water uphill without the use of electricity or fuel, and thereby changing lives tremendously.
Greetings from New Zealand. Stroke and cardiovascular diseases are the leading cause of death and disability in the world. Developed by Auckland University of Technology, our unique, validated, and internationally acknowledged digital tools for primary stroke and cardiovascular disease prevention could save millions of lives across the globe. Time to act, and act now.
Manu is a patient-level electronic medical record. So essentially it covers an individual's clinical record from the beginning of their life until the end of their life. Manu, it's a digital system and it's sync-enabled, which means that we're able to work in really remote areas in the countries that we implement in, where they may not always have a stable internet connection.
The non-profit entity of Blue City has been taking advantage of various information technology functionality of Blue just to promote health education, PrEP and PAP accessibility, HIV counseling and testing, and CBO networking all over China. The cutting-edge functionality in press, splash screen, banner, private messages, live streaming, online and offline testing reservation, anonymous online cohort, and so on.
A new artificial intelligence messaging app aims to speed things up. Doctors can type in their questions and receive a reply with the relevant information instantaneously. Over 500 NUH healthcare professionals have been piloting the messaging app so far. And the creators of the AI chatbot say they expect the app to get more useful as time passes.
So we built our own chat engine, which is entirely medical. And the idea is that it is trained by users as they're using it. So every day that they're querying it, the bot is learning. And because all of them are doctors or nurses, a lot of what we do is to use that to train the AI to be better.
Carbgen is a Japanese startup and has been developing the medical device software BitDie. The AI application can tell the name of bacteria from microscopic images of green stain. BitDie is also linked to the antibiogram like WHO's AWARE classification, and it can recommend the proper antibiotics. With the help of BitDie, Carbgen aims to reduce inappropriate antibiotics prescriptions and prevent the occurrence of antimicrobial resistance.
Hi, I am Troy Spilapil of CareGo EMR. Our innovation is a vaccination management field application and community engagement system, focused on streamlining the processes of health workers on the ground and increasing community participation in health programs. Through our co-developed solutions, we aim to increase the vaccination rates to at least 95% to keep children safe from vaccine-preventable diseases in Southeast Asia, starting in the Philippines. Thank you.
Even before COVID-19, healthcare frontliners already face many challenges, physically and mentally, and even more so now. In response, the Department of Health's Health Promotion Bureau partnered with AHA Behavioral Design to develop mental health tools for our public hospital workers to improve their well-being. We designed context and insights-based prototypes that nudged breathing behaviors, grounding behaviors, gratitude behaviors, and for supervisors, team check-in behaviors. When tested and validated, using the tools resulted in a significant decrease in perceived stress and a significant increase in positive affect and work-related support. To date, over 1,500 frontliners have been using the tools, and it's our goal to bring this support to more hospitals in the Philippines.
I am Jeremiah Calderona from FHI 360. I work on a USAID project to address tuberculosis in the Philippines. TB continues to be a public health concern in LMIC countries like ours, and the COVID pandemic has made TB services inaccessible to at-risk households in the communities. My innovation solution is to address this gap, promote TB preventive treatment, engage at-risk communities, and integrate mathematical models in policy development and participatory governance.
PAN procedure is a novel percutaneous cardiovascular interventional therapy guided by ultrasound instead of X-ray. It provides patients a safer, more accessible, and economical treatment without general anesthesia, open heart surgery, iatrogenic radiation, and contrast agent damage. It expands procedural indications to pregnant women and patients allergic to contrast agents or with renal impairment. It can save numerous patients in underdeveloped areas without expensive catheter lab.
In 2016, Health Futures Foundation Incorporated implemented a project to reconstruct the health system in Salcedo post-Haiyan and to reduce the burden of NCDs. To achieve these goals, innovative strategies were employed: municipality-wide, community-based, universal health coverage, NCD health ambassadors, holistic and integrative, active screening and follow-up, Alaga Ka Health Passport. With innovations, what seemed impossible was achieved.
COVID-19 is raging through the world. Despite the availability of effective vaccines, vaccine inequity continues to widen globally. For people who have yet to be vaccinated, Nudge AI can devise an intervention tailored to each individual. Using AI, we can effectively address individual behavioral traits and persuade people to get vaccinated in a timely manner. Nudge AI, saving lives through smart texting.
I'm Associate Professor James Trower from Monash University. We worked with the WHO Western Pacific Regional Office to support Malaysia and the Philippines in their COVID-19 response. We had a focus on capacity development for those two countries and worked with many stakeholders and policymakers from Malaysia and the Philippines. And we also developed open source computational tools that should have broader use going forward.
CHAS, a comprehensive intelligent hypertension management system. It is a multifaceted intervention tool to be used in general practice settings, comprising home blood pressure monitoring instruction, intelligent voice reminder, decision support for drug prescription, and data monitoring for quality improvement. Primary care physicians said it was helpful for them to manage their hypertension patients.
With a human-centered approach, the project enables students who could someday be affected by non-communicable diseases to shape impactful interventions. The project leverages a web-based and mobile-based application to provide students with tailored knowledge, skills, and support to practice non-communicable disease prevention. The application is central to a digital ecosystem that connects our target audience with relevant stakeholders and can be utilized for the prevention of other diseases.
Sante IMS's functionality delivers person-centered, seamless immunization program management and once-and-done workflow from point of care to supply chain anywhere. It works offline from tablets to desktop. Its privacy and interoperability by design maximize return on existing and future investments. Its proven, high-impact benefits include improved coverage, reduced zero and missed doses, accurate, near real-time automated reporting, and reduced vaccine wastage and stockouts.
In response to the emerging need for an innovative surveillance system, we developed Honghu Hybrid System, known as HHS. HHS innovatively integrated data from both traditional sources as well as newly emerged sources, including social media on mobile devices. HHS was successfully deployed within 72 hours. It enhanced full-spectrum management of COVID-19. As commented by local authorities and IMEA reviewers, HHS accomplished an impressive achievement and offered a schematic for how other jurisdictions might leverage health informatics systems to manage a pandemic.
People and their interpersonal relations are a valuable asset in the community. Thus, we have developed the IMPACT program to building, strengthening, and sustaining the relationship within individuals and across people with diverse backgrounds to improve ethnic minorities' accessibility to cancer screening services, reduce health disparities, and ultimately to achieve the Sustainable Development Goal 3, ensure healthy lives and promote well-being for all.
Innovation is about change to systems and change to the way people act and interact. Technologies can solve big problems, but only when adopted at scale. The Fred Hollows Foundation is interested in finding better ways to tackle the technology uptake challenge. In Vietnam, we're working on the question of how AI technologies can be used to reduce the risk of sight loss for people with diabetes. We're partnering with the Vietnam government and Australia's national science agency, CSIRO, and working together to find ways that technology can make eye care cheaper and more accessible.
Hi, I'm Associate Professor Torsten Seaman, and I'm the Head of Bioinformatics at the Public Health Lab here in Melbourne, Australia at the Doherty Institute. I'm also the co-founder of AusTracker, which is now Australia's national pathogen genomic surveillance system. Over the last 2 years, AusTracker has been used by states around Australia to both share data and investigate outbreaks during the COVID pandemic.
Hi, my name's Dean Johnson. I'm the International Development Lead for ThinkPlace Global. ThinkPlace is a strategic design firm with offices across the world, and we're committed to making sustainable change at scale. We're here today to introduce our innovation, which is using variable reward systems to create SBC interventions that have made significant impact in changing behaviours around nutrition and well-being.
Welcome to Clip Mobile UC.
I'm Dr. Azina Mokhtar, Director of Clip Mobile UC. Clip Mobile, leaving no one behind.
Welcome to MySTEMI. Heart attack is one of the leading causes of death for the Pacific region, Southeast Asia, as well as Malaysia. 2 out of 10 patients with heart attack will die. It carries financial burden if patients are not optimized appropriately. In My Heart STEMI calculator is artificial intelligence based and is population specific. It calculates the risk of death. This will ensure better risk prediction with optimization of resource to ensure better survival. It has high potential to be used globally.
Environmental degradation and climate change poses a threat to child survival, health, and well-being. It's time we put children's rights at the center of environmental health and climate action. Vital Strategies Innovation creatively unites existing national and subnational data and integrates them with global evidence to create Children's Environmental Health Indicators Tracking Program. We piloted the program in China and Myanmar to track and identify climate and environmental health threats to children and to enable environmental interventions and policy evaluation. It's time we give our children the safer and cleaner world they deserve.
I would love for us to be all together in one room and to be able to give audible applause to the ingenuity and the commitment, the dedication of so many innovators, academics, entrepreneurs, people with great ideas and commitment who have contributed to this wonderful list of innovative solutions that have covered all the thematic priorities for the future vision for our region, who have shown relevance, who have used techniques that range from the high-tech clinical interventions through to digital and AI, as well as very down-to-earth primary care, water pumping solutions that we have seen deployed and celebrated here. You will get a chance to meet these innovators in our problem-solving sessions later today. And also, as we shall highlight a number of times during the proceedings of today, the details of the winners are available on the innovation section now of the WHO Western Pacific website. It is my pleasure to now move on to our first keynote, and I invite Professor Yuichi Tei, Dean of the School of Health Innovation, Kanagawa University of Human Services, a colleague and friend in the innovation journey of the Western Pacific. He and I have most recently been often co-facilitating workshops and webinars on health innovation. He has made it his mission to prepare both academically and practically the innovators of the next generation. And it is my pleasure to invite him to discuss on how we achieve that part of our mission in his keynote speech. Professor Tei, over to you.
Thank you very much, Dr. Galea, for kind introduction. And I'd like to thank the organizer for inviting me to this very prestigious event. So let me share my slide. Can you see?
It is, yes, it is not.
Yeah.
Yes, okay. We can see it now. Over to you, please.
Thank you very much. So I'd like to talk about this title. And I'm now in charge of designing an open innovation platform at universities. So I'd like to focus on the key roles of universities in health innovation. So sooner or later, we will face 100-year life, and we have to think about it. And we backcast based on the vision 100-year life. There are two things that require imminent attention. They are data system reform to build a new data platform integrating medical care data with daily data and the daily life data for big data analysis and the new value creation. And another is the other is a social system reform. So especially work style. So no retirement age in the near future, no dichotomous opposition between elderly and the young. Any healthy person can continue working as long as he or she wishes. And the insurance system also has to change. Payment for promoting or keeping health now. Payment for promoting or keeping health, not for losing health. We are now getting money from the insurance company in compensation for lost health, but it has to change. So apparently, we need disruptive innovation, both technological and social. So our university started a new school called the School of Health Innovation, where we foster next generation health innovators. So based on public health, our school offer a curriculum to acquire the mindset and skill set necessary for driving innovation in health. We aim to research and systematize a MEBIO concept, which is actually very similar to the intrinsic capacity concept by WHO, healthy aging, which will help make aging society sustainable. There is an interesting analysis between diversity and innovation. Let me a little bit go into detail. So this is a paper by Lee Fleming, and he showed the correlation of member diversity and innovation value in the financial value of a patent. So he analyzed various patents. X-axis is the team's uniformity, so opposite to the diversity. So the more on the right-hand side, more diversity. And Y-axis is the value of innovation of a patent. So higher the Y-axis, the more value in innovation. So apparently, if you have a team of diversity, more diversity, the team members are the more values of innovation. But at the same time, if you look at the average success rate actually decreases when the diversity of team members increases. And for social and technological innovation, I just talked about, we want this area. But if you just think about diversity, apparently diversity alone does not suffice. We have to think about decreasing these failures. So now I'd like to talk about the important roles of universities balancing success and the failures. So what are the key roles of universities in health innovation? I just heard the wonderful innovations by many different stakeholders just awarded. So the first one is very apparent. So to create a place for as diverse stakeholders as possible. I think everyone agrees. So for example, so the creation of an open innovation platform is very important. This is an example I experienced in Center of Innovation at the University of Tokyo. So state-of-the-art science and technology sees matching the vision plus corresponding needs of industry and the municipality and the government, and they come to the open innovation platform. And in the open innovation platform, there are various stakeholders in work. Hospital, medical economists, regulatory agency, standards organization, IP, funding agency, so on and so on, with some network and also educational system. So involvement of all stakeholders in various sectors from early stage of R&D is the key for social implementation through speedy R&D, human resource development, and policy proposal. So I experienced this. So here at our school, we achieved the diversity of professors gathering talents across disciplines, not only science, but also the engineering, the economics, and business entrepreneurship, and so on and so on. So we are to some extent successful in gathering. In terms of students, we also gathered diverse students. The left-hand side is the professions: nutritionist, pharmacologist, nurse, physical therapist, clinical engineer, veterinarian, physician, IT specialist, human resource specialist, business consultant, public officials. And on the right-hand side is the workplaces: hospital, nursing home, pharmacy, local central government, university, research institute, and many different companies. So we successfully gathered talents across diverse sectors. But as I pointed out at the beginning, citing Lee Fleming's paper, successful team formation with diverse team members does not suffice. We need another factor. So second key role of university, I think, is to encourage cooperation of diverse stakeholders by distinguishing common and specific areas. In other words, setting a common minimum set of discipline. More in concrete, universities should draw a line between non-competitive, common areas and the competitive areas, specific areas in R&D. As for non-competitive area, university put all stakeholders under one roof and catalyze their cooperation. As for competitive area, university should leave the roles to the companies, and the companies should compete with each other. So this formation, I think, is very important. And the universities, as a non-profit organization, are best suited for this position. So there are two key roles of universities: create a place for as diverse stakeholders as possible. So it relates to the diversity. Second one is to encourage cooperation of diverse stakeholders by distinguishing common and specific areas. It relates to setting a minimum set of common discipline. So apparently there is a trade-off between these two factors, but the universities should balance these two factors for efficient innovation in health sectors. Let me showcase one example. So he is the second batch of students, Daisuke Inagaki. He's actually clinical engineer. So he register, manage, and also provide education about medical devices in the hospitals. He did lots of volunteer work in developing countries, including ASEAN countries, and found problems like cumbersome administrative tasks, loss of treatment opportunities, inadequate medical device education surrounding medical device. So he now set up a venture company and proposed an IoT system, which provides registration and management, and also provision of education contents. And many students now follow suit to come up with the social and the technological innovations. So I think universities are very important, providing the human resource ecosystem in the health innovation. Thank you very much. Dr. Galea.
Thank you so much, Professor Tay, for that rapid overview and with the introduction of the key words of diversity, value, competition, the role of universities complementing that of companies and of government, preparing us for the 100-year life and backcasting to the disruptions that we need to see in technology and in society. As we help and join in that journey, I turn to my partner and the acting director of Data Strategy and Innovation Division, Ms. Amy Cawthorne, to describe how we are working towards developing a Wipro strategy for innovation, inspired by the type of key points that have been raised by Professor Tay. Amy.
Thanks, Gordon, and welcome to the nearly 300 participants we have joining us of our growing innovation community and partners in this region. So I've got the pleasure of your virtual company today to talk about scaling innovation for public health benefit and looking towards strategy in the Western Pacific region for innovation. And I've got a few key messages during the next 5 minutes for everyone to listen to, maybe reflect on a little. First one is that innovation is going to be one of the keys to driving forward achievements of the SDGs, to making sure that we achieve the desired future that populations and governments want for health, well-being, and health systems in the region. It's also, we need to have a call to action, because to unleash this potential, we need to create an enabling environment, and that means changing the way we do things. And thirdly, to give a bit of a description of a commitment from WHO to support that change in the development of an innovation strategy in the region. So innovation is the key. As the regional director, Dr. Kasai, mentioned in his opening speech, the For the Future vision paper describes a commitment from countries and WHO in this region to becoming the safest and healthiest region. It places health innovation at the center, naming it as a fundamental shift in the way that we value and create health in our region. It defines public health innovation as the creation and implementation of a novel process, product, program, policy, or system which leads to improvements that impact population health in everyday life. Now, the urgency to innovate stems from what we value and what we want to achieve in the future. From those commitments to achieving SDGs, to addressing emerging issues that require lifelong and non-health sector approaches, such as non-communicable diseases, population aging, mental health, climate change, to preparedness for emerging health threats, and to achieving that desired future for the health systems that will serve the people of the future in environments and societies of that future. And as our first keynote speaker talked about in his opening remarks, disruptive innovations are the key to achieving these changes. And you could almost argue that without disruptive innovations, we might never get there. I also want to reflect on some of the cross-cutting agendas, such as advancing health through the attention to gender and equity, which also call for new approaches to engaging health programs and partners, to identifying and asking critical questions, and to encouraging dialogue. Even in the traditional areas that WHO works in and has done since its inception around disease control, they may well have established and effective interventions, but innovations can help them reach more, achieve more, and ultimately save more lives in this region and beyond. So the call to action, it's not to say that there's no innovation going on in this region, but there are roadblocks to scaling it up. Innovation doesn't happen overnight. It takes time, it takes effort, and it takes investment and a certain amount of risk. And that can be hard to prioritize over established solutions, but the rewards can be significant. And when we talk about rewards, we're talking about creating healthier populations that live longer. So with that, too often, there are no adequate mechanisms to systematically identify, evaluate, and prepare viable solutions for amplifying information. In other words, what we need to have in place to achieve the great things that innovation can deliver for health, we need to have better governance of innovation to foster and deliver both radical and incremental changes to get what we value to achieve health for all. Also, market failures and deep structural flaws exist in the current health innovation ecosystems. The way that we finance health innovations and the way that that's structured doesn't really help us achieve what we need to achieve. Money is often insufficiently mobilized for solutions that fail to address the underlying causes of long-standing structural problems in health. And the capacities it builds and the impacts it creates are not equally distributed across societies, amongst the advantaged and the more vulnerable groups. Both immediate and long-term changes are required to reimagine and redesign the health innovation ecosystem for the common good in the region. Innovations must be purpose-driven. Capacities of the public sector in governing health innovation must be strengthened, and a different form of symbiotic public-private partnership should be built to steer health innovators to innovate for common good in the long term. Now, redesigning the health innovation ecosystem requires a major shift. It requires a shift from a model where innovation is being driven by market forces to a model that is collectively governed in the public interest. With this shift, government's role fundamentally changes in health innovation. It goes beyond a role where they fix market failures to a role where governments are more ambitious. They lead health innovation. They orchestrate collective performance of many actors. One of the challenges of wearing a mask is the sound can be a little sketchy. So we're just moving my microphone closer. So as I was saying, so government roles really do change with the shift that we need to see if we want to create an environment where innovation is fostered, it's scaled, it has impact, it helps us achieve those long-term goals. And I think where we want to be is where governments, through setting the vision and direction, create the space and the environment to incubate, evaluate, and institutionalize innovation, and therefore change the health for all approach that we want to see and achieve everything we want to achieve to be the healthiest and safest region in the future. And finally, I'd like to end on a commitment to support change. And this comes from Wipro and what we will do from the WHO perspective and our commitment to support the innovation ecosystem and support member states. Now, there are some examples of where we've been working so far, and that's around studying the innovation landscape in the region, the health priorities, the trends, the unmet needs, the health innovation capacity, identifying and connecting with innovation institutes, and that's one of WHO's sort of founding requirements, our constitutional requirements around convening, bringing collaboration regionally and globally, working with partners and countries to undertake research and curate solutions for deployment, and for innovations in action, supporting countries in the evaluation and measuring of impact on the lives saved and the movement towards the goals that they intend with that innovation. Now, this virtual gathering is a platform to disseminate innovation initiatives with proven impacts in member states. It's also an opportunity to facilitate problem solving in real time and a time to reflect on how impact of innovation is being measured across the region. The output of this forum is really important because it's going to feed into the development of a regional health innovation strategy that's going to fulfill part of the commitment that's actually documented in the For the Future vision paper. And we want to work collectively with you today and in the future to achieve the goals set forward around innovation and what we want to see in terms of scaling and impact in public health in the region. And to leave you with a little thought, the future is already here. So let's embrace it with our creativity, our courage, our partnership, our collaboration, and most importantly, our willingness to change. With that, I would like to hand back to Gordon.
Thank you very much for that broad overview of a future strategy, looking at how we shift the role of government from purely correcting market failures to actually institutionalizing and leading innovation in public health. In order to quickly take us to the discussion on how the challenge, for the rest of today, we shall be interacting with the innovators in 3 sets of problem-solving sessions with the collaboration of the Health Innovation Challenge winners. But to introduce that process and how we built the Innovation Challenge, I turn to our colleague Jeremy Ware, consultant in the Innovation and Research Unit of WHO Wipro. Over to you, Jeremy.
Thank you, Dr. Gordon. I would like to talk about the Innovation Challenge today and just guide everyone through exactly how we prepared that challenge. So, next slide, please. The Innovation Challenge started in September 2021 when the World Health Organization Western Pacific Regional Office called for innovators with public health solutions for the region. A total of 468 entrants registered for the challenge from 49 different member states. And out of these entrants, 153 entries following eligibility screening were assigned to the initial judging phase. For the initial judging phase, we had 32 judges from a very diverse background. We had young professionals. We ensured gender equity with 55% of female, 45% male judges, and diversity whereby we included judges from outside of WHO organization. After the first round of judging, 50 entries were selected to move into the next round of judging, whereby we had an additional 26 judges from academia, NGOs, and private innovation organizations who reviewed the entries over a 3-week period and scored them using the criteria that we had set on novelty, scalability, impact, relevance, and adaptability. From these 50 entries, we finally selected our winners, which are 29 entries. You have seen the videos from our winners already today. Of these 29 entries, 11 member states are represented. And we will be inviting the 29 winners to participate in the problem-solving sessions, which will be happening later today. Just to provide some statistics on the Innovation Challenge, you can see that we had 27 different countries that submitted entries at the start, and we had a very balanced range against our categories which were set. So COVID-19 innovations, disease elimination and control, health security and emergencies, healthy environments and populations, and universal health coverage. I will now spend some time to recognize innovators from outside of the challenge. So together with our 29 challenge winners, our headquarters and colleagues across the Western Pacific region, we would like to recognize contributions that's been made by the Million Lives Collective. The Million Lives Collective is an initiative launched in 2019 that raises awareness of innovators and social entrepreneurs making a significant impact in addressing global development challenges, as well as the ecosystem partners that contribute to their growth. They are highlighting innovations which have reached and served over 1 million clients. So I will quickly talk through some of the innovations that the Million Lives Collective has done. Simprints has been implemented in 16 countries across sub-Saharan Africa and Southeast Asia. So this is a digital identification solution designed for frontline service providers. WeCare Solar Suitcase. This was implemented in 20 countries across Africa and Asia. And this is targeting over 1 million babies and close to 300,000 women who lose their lives each year through complications of pregnancy and childbirth. CAD4TB is a Delft Imaging's innovation, and this has been implemented in 41 countries across Africa, Asia, Europe, and South America. The e-compliance suite was implemented in Western Pacific regional countries, including Cambodia, Uganda, Dominican Republic, Kenya, India. The next is high volume cataract surgery and training model as a cornerstone to strengthening national eye health programs. Then we have Restoring Vision, which was implemented in 136 countries. A self-sustaining Wolbachia method implemented in Vietnam, Indonesia, Australia, Colombia, Brazil, and Western Pacific. And SureChill implemented in Australia, Papua New Guinea, and another 60 countries. And finally, Sato Pans and Stools implemented in 22 countries across Africa, 11 in Asia, 6 in North and South America, and 2 in Oceania. And this is really the goal of today. The session is titled Innovation for Impact. And we are seeing through the Million Lives Collective that they are really driving impactful innovation. Finally, I would like to give special recognition to the Go Youth Global Open Call 2022. This is a global competition open to youth between 18 to 35 years old. It's a crowdsourcing open call with to identify youth-led social innovation in health and support them in further research. So if we have any participants today who would be interested to register, please scan the QR code and follow the guidelines. Thank you all for your attention. I will hand back to Dr. Gordon Galea.
Thank you, Jeremy. So that gives you a very rapid taste of how the Innovation Challenge was managed, the scale of the participation, the range of the solutions, and also connects to a few examples that were identified by the Million Lives Collective. The awardees of and the winners of our Innovation Challenge, plus the solutions highlighted by the Million Lives Collective, represent a pipeline of innovations, such as one would see in a country that is institutionalizing innovation. The rest of this day will have 3 problem-solving sessions that will look at different stages of innovation, of the innovation pipeline, ending up with scaling for impact. For the first problem-solving session, our moderator will be Christopher Bates, Technical Officer in WHO Pacific Island countries and area. And he will be convening a group of panelists from among the awardees, and I will leave it to Mr. Bates, to Chris, to introduce his session, the problem behind it, and the interaction with our colleagues from the innovators. Thank you very much. Over to you, Chris.
Thank you. Thank you very much, Dr. Gordon, and thank you everybody for joining this important session for sharing ideas in innovation across the Western Pacific region. I am moderating a session with some of the innovators who won the challenge last year. You saw their short videos earlier. And we've been presented with a problem from the Laos PDR by one of our colleagues to do with the healthcare workforce, policies and education. I will not be able to do it enough justice and detail to introduce it myself. So I have the pleasure of introducing Moe Ando, who is from our country office in Laos, and she will be able to give a bit more detail. Moe, will you please introduce us the problem?
Thank you very much, Chris. Okay, good morning, everyone. I am Moe Ando, a midwife from WHO Laos. It is a great honor to have this opportunity to borrow brains of innovators to think about solutions for policy issues in Laos. Okay, let me share my screen. Today, I will present our policy problem about our problem, systematic and continuous adjustment of healthcare workforce policies and education to reflect changes in the Rural Health Service Package database. This illustrates a policy situation of midwifery workforce policies and education in Laos. Essential Health Service Packages, EHSP, defines 48 services that should be provided by midwives. In order that midwives can deliver required services efficiently, it is important to ensure that workforce policies and education support midwives to provide essential health services. First, it is crucial that regulations legally allow midwives to provide required services. Second, it is important that competency policy and curriculum equip midwives with required knowledge and skill to provide essential health services. To assess if workforce regulation and policy education are supporting essential health services provision by midwives, WHO Laos created EHSP database and conducted a policy gap analysis. Then we found out these policies and education are not fully supporting essential health services provision by midwives. This is a visual image of EHSP database and showing the result of the initial policy gap analysis. In the EHSP database, we listed all the essential health services in reproductive, maternal, and child health, combined with required clinical procedures written in national standard guidelines, which were developed based on WHO recommendations. Then we mapped out all the documents against this national standard list to find out what components are missing in each document. Last year, the analysis revealed that regulations support only 25% of the essential services, competency in policy only support 50%, and curriculum support only 23%. Based on the result of this mapping, we informed the government about required revision points and supported revision of regulation and competency policy in comparison with UNFPA. This is a result after the policy revision. Now, regulation covers 95% of the essential services and competency policy support 85%. This outstanding policy improvement shows that the EHSP database can allow the government to systematically inform all policies about revision points. Every time WHO recommendation come out and national standard list is updated, healthcare workforce policies and education can be timely updated. Now the government is showing their greatest interest in extending this mechanism to other health cadres, such as medical doctors and nurses. However, we are questioning to ourselves, will this database be used for policy revision in the future continuously? Our answer is unlikely. In today's session, we would like to think about how Laos can institutionalize this database to ensure systematic and continuous adjustment of healthcare workforce policies and education to reflect changing evidence standards. There are three challenges that prevents the government to utilize the system. First, ownership. Currently, WHO Laos owns the database, but the government should own it. A well-designed governance should be in place to manage a database that includes different policies taken care of by different departments of the government. Second, database format. The database format should be user-friendly. Changing the current format of Excel to an ICT system might help the government people to deal with continuous update of the database more easily. Third, inclusion of global WHO recommendations in the database. Current database includes only national standards. If that database includes a computerized system to systematically WHO recommendation into national standards, reflection of new evidence can be done in more timely and systematic manner. These challenges need solution ideas from the innovators. Similar policy issues were reported in many countries. Establishing this database has a great potential in scale for impact in the UPRO region to achieve universal health coverage. Therefore, we believe today's session will be also helpful for other countries. This is all for my presentation. Thank you very much.
That's great. Thank you, Moe. And I don't know whether it's right to say thank you for a problem, but it looks like what you have presented, there's been some excellent progress, which is something that needs to be maintained. So as I mentioned, we have a group of innovators who have been looking at this problem, which has been presented to us. I would like to take some time today to display to people and show some, let's try to call it maybe live discussion, live innovation, and kind of freestyle through the discussions that start off the innovation process. I would like to introduce one by one the team who have been working on this process. And so when I introduce you, please feel free to turn on your camera, give a wave if you're already there. So to begin with, we have Dr. Sazli Kasim. Dr. Sazli is a cardiologist with a master's in health economics. Hi, Dr. Sazli. He is the founding director for the University Technology Mara Teaching Hospital in Malaysia and is active in primary and secondary prevention research, involved in health policy, planning, and strategic program rollouts. We also have Dr. Xianbing Pan. Dr. Pan is the inventor of percutaneous and non-fluoroscopical procedure, the PAN procedure. You might have seen that in the videos earlier. He is a hybrid cardiac physician, director of Structural Heart Disease Center from Fuwai Hospital of Chinese Academy of Medical Sciences. We also have joining us the Associate Professor, Dr. Azlina Mokhtar. And Dr. Azlina is a public health ophthalmologist in University Sains Islam, Malaysia. Her work is teaching and contributing with national ophthalmology, supporting their program and planning on community eye health toward universal eye health coverage. We also have Luda Yang with us. Luda works for CarbGem's corporate planning department as a project manager and handles the collaboration project's multi-sectoral partners. Currently, his major focus is an AI application development project to promote the proper use of antibiotics in Japan, Vietnam, and a number of other countries. We also have joining us Auke Itzenga. I should have apologized in advance for some terrible pronunciation of names. Auke is a Dutch marine engineer who is in the Philippines working with appropriate technologies among the poorest. He is the co-founder and CEO of Alternative Indigenous Development Foundation, and you saw this video earlier as well, an interesting project whose main focus is to supply remote upland waterless communities with water through holistic ram pump water systems. We are joined from Canada by Joseph Delmoulin. Joseph is a co-founder of Santé Suite and a recognized expert in open innovation in digital health. He helps Pacific Island countries leverage Santé Suite's immunization and client registry solutions to create a person-centered digital health ecosystems. And lastly, but certainly not least, is Yu Fei, who is Deputy Director of Medical Affairs at BlueEd, a social networking app that connects one of the largest online LGBTQ communities in China, providing health education advice. Welcome again to all of our innovators. And I would like to, therefore, now that we've met the innovators, we've been introduced to the problem, I will just share a little Jamboard. that we can work off while we're discussing through the problem. So let's jam. Where to start with such a problem like this is, how shall we discuss defining the problem? Do we fully understand the problem that's been put forward to us about the EHS database, the curriculums, the policies for midwives? Does anyone in our team want to start off some of the discussions? The final question in the problem statement that we were given was that, can we develop a system that is in Excel, that has already been presented by Moi? Can we make that scaled up and applicable to other countries in the region?
I'll probably go first, Christopher, if you don't mind. I think Moi have presented a problem very succinctly, and we've all agreed that there's a lot of problem in that problem basket as is portrayed. But really, the first thing to do is to dissect it down and to try and figure out what is the real issue. The real issue is to try and tackle maternal mortality to get to the rural areas, as well as to strengthening the whole healthcare sector. And there's also this diversity in terms of healthcare provision in the country with multiple stakeholders. Therefore, you have disparity in terms of how guidelines and trainings and delivery is being delivered. So her question in her slides is very pertinent, i.e. she has a system, training is on board, the system changes very frequently, delivery of changes to the end users, i.e. the healthcare providers, the village trainers, not very clear and sometimes could be a miss. And therefore, how do you maintain integrity of the whole structure and ownership? So I think it's not a very straightforward problem. There's a lot of discussion that needs to be done between who owns the data. So there's a lot of stakeholders that needs to be bought in. How do you create the system? There's financial implication. Do you want to pass the system over to the country to let them run in the future? That's probably cheaper. Do you want to buy or develop your own system in the future for this particular use? How do you protect data integrity? That's all the ICT component. And maybe at the end of it is, how do you deliver the system out, and how do you make sure that people use it? And how do you decide on the reporting of the usage of the system and whether or not it's effective? So maybe I'll just kick off like that, and the rest of the team can pick up and see what you think.
Yeah, but that's really important. That's something I come across as well. I picked up on the reporting issues. What is the real use of a database like this if it's not being used for something, for reporting? What is the information that's coming out of it, really? And how is it going to be maintained? Yes. So there is already a proposal, really, of scaling up using an ICT platform, which is currently Excel and not really scalable, not really user-friendly.
For me, the main issues that we need to highlight in this particular problem is who is the ownership first. Because when we have be clear about the ownerships, the next step afterward is more easier to handle it, because the owner, we clear who is the owner has a custody for it to controls and for the legal rights and also for financial supports, right? So the first thing that very important is to make sure the ownership is clear. Who is the ownership?
Right, and that person would be accountable for it. Okay, I just saw you had your hand up as well. Sorry, I missed the opportunity.
Okay. Hello, good day. When we talk about ownership, it nearly sounds like a legal question. But I think to make any system sustainable, we need to create the sense of ownership within the levels of different users. So we have to identify the different groups of users in this database, or can there be different levels created in this database so that people involved in those levels can really feel the connection to it, meaning creation of a sense of ownership.
Okay, great. Important root causes, root questions that we're delving into there. You can see now how we're going from one level to the next as we go into what are the key questions. Dr. Pan, I'm sorry, I think I might have interrupted you.
Thank you, my dear colleagues. So, as we all know, Lao government plans to achieve the universal health coverage in 2025. However, the poor information system serious impact on their strategy improvement. So, I'd like to share our experience for the database development. There are two major problems I'd like to share. First is that how to ensure the accessibility and accuracy of the data, and second is how to use the data. Now come to the first problem: how to ensure the accessibility and accuracy of the data. In the basic infrastructure training program and human resource support. Also, you need to simplify the procedure of the information input, optimize data updates and reporting systems. Otherwise, no one is willing to use it because the doctor and the nurse and the assistant, they are very, very busy. They don't have enough time to input the data in our systems. And meanwhile, if the database want to be widely spread over all healthcare hospitals, the function of the database will need policy support to improve and maintain the database. And the second problem is that how to use their data is very important. If the Lao government and our colleague in Laos, they have so many benefits from the system, they will want to use the system and help the WHO to improve the medical quality in Laos. This is the key part. It's not only need regulation, policy, and implementation, but also it needs innovation to solve the problem. For example, just like in China, our database is under the National Cardiovascular Center. The data show that the mobility of congenital heart disease is very high in Yunnan province of China. Then we can have the suggestion to Chinese government, and we carry out some special program to support the congenital heart disease in Yunnan province. And when we carry out the program, however, we find a lot of people without which congenital heart disease in Yunnan province are living in rural area, which limited medical resource. So we help them with the innovation. Just like this time, so we provide a PEM procedure, percutaneous and no fluoroscopy procedure. We can use the mobile echo machine to perform the percutaneous procedure for ASD, VSD, PDA. So we don't need a cath lab. We can bring the echo machine to perform the procedure in village. So what I want to mean is that with the help of the system, the information database, we can find problems and we can help the local doctor or government to solve the problem by innovation. Yeah, that's the key point. Thank you.
That's superb, thank you. And what you started with at the start and at the end is something that really needs to be highlighted in this process as well, is that it's your experience that you're bringing to this problem as well. We have a quite diverse range of people in our innovation team who are bringing lots of different experiences. And that's different ways of thinking towards what is the real issue that we're looking at. Luda, What have you got to add from your experience?
Besides the ICT system itself, I think there's another thing we need to consider is how can we leverage this ICT system, and because we need to consider the dissemination of guidance or standards, especially when we talk about to scale up for impact, right? So so after the development of this system, it cannot be only stayed in the database. It should be disseminated to the each end user, each community. In that way, we can, make this change. I think that's my point to how to leverage this system.
So, Luda, were you referring to the system that currently exists, or if there's going to be a new system, how to leverage that?
I think in both ways, even in the existence and the future one, we need to consider to how to leverage, let people to use the system, and by doing that, the policymakers maybe can see the benefit by using this system, and then it will motivate the government to update the system. I think that is really relevant to the other issues.
Okay, so I think that's a really important point as well, is since we figured out there's some themes here about maintaining the integrity of the database while things change frequently. And there's lots of disparities, things aren't standardized. But what is the motivation, this guy here, for the government or the user to be updating this all the time? Okay.
Just like to say about the data protection a little bit. Where when we have ownership, there is specific governance that we need to build up. Because from the governance itself, there is a terms of reference, right? So from the terms of reference, TOR, so we can highlight who will be the managed data. So from the managing the data itself, there are stewards to see the improvements, or to see how monitoring the security of the data itself. So the governance is very important when we have a specific ownership.
Yeah, okay, I see. I can see where there's a web happening here. I'm just going to overlap that because ownership, stewardship, governance, all kind of linking together. Thanks, Dr. Azlina. So there's a bit of a web starting to emerge here. So we started with the problem of there being a database existing. It's in a basic software, but looking towards scaling that up because it was seen that it was successful in use for that analysis of the policies and the curriculums for midwives. And looking at the question, we're working backwards as trying to figure out let's say a hypothesis. Would this be right, team? Of what is the real issue? The hypothesis being, well, are we actually meant to be looking at data protection here? Is the problem the reporting issues, not just having a particular software or system to be able to implement? And working backwards, we're starting to see things about the motivation and ownership, stewardship. I'd like from the team, before we start to transfer back to Moe and the problem team, shouldn't say problem team, Moe and the team in Laos, how do we see this all linking together? And does any one of the innovators here have thoughts about the themes that are starting to emerge, which we might want to start to ask back to Moe?
Joseph here, if I can just jump in. So what I'm sensing is my understanding of the ownership issue is around being able to merge both the WHO and the country information. But what I'm also seeing and hearing in this, and I'm going to echo something that OK said with relationship to ownership at the frontline level in terms of the end user. Because what I think might glue this all together is the concept of a learning health system where you have dissemination, use of the information, its improvement based on evidence driven by the use, and then feedback into the governance of the information itself, who's responsible for governing and disseminating it. So creating that kind of a real ecosystem of information, which also involves the frontline workers, because ultimately their sense of ownership in using the data and understanding and using the information and guidance is what's going to be critical for it being effective. And also they're can often be the source of innovation. Over.
Okay. All right. So
Chris?
Who's that? Yeah.
I'm Moe. I'm talking. We need to finish in 18 or 16 minutes.
Certainly. Oh, just before I get the innovators to start to be questioning with you, I see that there's quite a few hands up from our innovators. So the top of my screen is Luda. Is that an old hand, or you've got something new to put on? No?
Sorry,
oh, well, that was easy to take off my list. It's Dr. Sasley.
Just to share with you in terms of the ownership, I totally agree. It has to be multiple bodies in there: doctors, the nurses, the midwives, the government is very important to own and be the steering committee. There should be task force looking at all the policies that comes out and being utilized and cascaded down to the end users. And the biggest problem there is to get the end users to actually be trained to adhere to the guidelines and to utilize the guidelines. So that's the mechanism. The motivation from our experience to tackle maternal mortality in Malaysia is we do mandatory reporting, where all death or all complications are reported to the district health officer and discussed in an anonymous manner, and then subsequently discuss at a high level, and then you have a dashboard reporting to the main committee to know exactly the numbers per over time, whether or not things are improving. So there has to be a lot of government buy-in, a lot of support from all the other stakeholders, NGOs, and etc. So I think that could potentially solve that issue.
Okay, and thank you very much. So I'm trying to pull things together here. So just some last comments. Okay, is that an old hand of yours, or you got some closing comments from our innovators?
Yeah, maybe a few points to mention, also to further look at things. So again, the chain of users. Then if there's a feedback mechanism, I think Joseph mentioned that quickly. And then because of the danger of assumptions for the ones who are making this kind of databases, and then at the different levels that it should be as much as possible simplified. So making it users friendly, or as much as possible appropriate for the different levels. So yeah, the danger of assumptions.
Right. Yeah, absolutely. And so there's a few assumptions that I think we've started to reveal in here. Just before I would like to hear from Moe, but just before that, just to summarize, because I think I've made this more messy than is necessary. But what we're looking at is the map of the conversation and the way brains are starting to think about things. That it seemed, if I understood correctly, having the feedback from the reporting to many, many places, the users and to those who are identified as the owners, is something which provides motivation to be able to keep the database updated, is what I'm starting to hear between linking all of these 3 or 4 main areas that we're looking at. So, and that was really condensed. It was just a brief look at the discussion and how we're working backwards from the problem we've been presented. And now we look forward to some critique from Moe, who was our presenter of the problem statement. What are your thoughts on what you're seeing here?
Okay, I think I should have been more clear about what is the user of this database. The database user will be usually, generally, policymakers, because the database should be used for devising and also developing guidelines, policies, and curriculum. So we are not expecting medical doctors, nurses, and other healthcare professionals in practice setting. We directly use this database and also report some events about them to the government. So I should have been more clear on this point. But I totally agree with we need to really clear about who should be responsible for maintaining and also financial aspect of the maintenance of this database. And I think I agree with the idea of, sorry, I forgot who presented that idea, but we might be able to organize a task force among those who are involved in developing different policy and guidelines and curriculum, so that they can cooperate to develop and think about who will own the database and who gonna maintain what part. And of course, WHO should be involved if he want to include international WHO standards to be in this database, because that part, connecting WHO recommendation to national standards should be done by WHO. So the ownership should be in the government, particularly for the process of updating national standards and reflecting that new national standards into policy revision. That part should be owned by the government, but connecting WHO recommendation and national standards should be owned by WHO. So the ownership, the modality of the ownership will be that kind. That is my thought.
That's excellent. Thank you for your clarifications. I've just put in there a little about that it could be governed by a task force. Fits nicely into this little triangle that's been set up about government governance, but also come from multiple health areas. So I notice Dr. Golden.
Thank you, Chris. Not formally part of the panel, but there's an active discussion happening on the side. And so I thought I would add a couple of points to the audience and the participants to have a look at some excellent points being made in the Q&A box. If I may summarize a couple, one of the participants who did not put their name in, an anonymous attendee, pointed us to the WHO ITU eHealth National eHealth Strategy Toolkit. There is a resource that is pointed to on the Q&A section, as well as the reference by another attendee to WHO's recently launched SMART guidelines, again linked to in the discussion box. I make these 2 points because, of course, innovation does not happen in vacuo. It happens, each innovation builds on other innovations and can use existing resources. One final point that I would add from my own observation in COVID, WHO has started to adopt the tool called Living Guidelines. I will put a note here in the Q&A section. These living guidelines are a way of coping with constantly evolving evidence context. And for those who want to be up to date in their guidance to healthcare workers in the country, they have this is one way in which such guidelines can be brought together and disseminated. I also want to conclude with our colleague Yang Vanra's comment from WHO in the country office, talking about 3 types of users and owners. Those who own the data themselves, the data subject, the patient who owns their information, the data processors, the holders of the database, such as the hospital, and the data controller, the MOH or the government. That is different. When developing such an application as this, it requires that the different roles be identified. I hope that I reflect the discussion. Hand over to you with a little hint that we have 8 more minutes for this section.
That's well noted. Thank you, Dr. Golden. And so there was one thing that I was thinking while Moya was talking and while you were speaking as well about how what is being developed, like you were saying, living guidelines. This is kind of a living collection of guidelines that is trying to be formed. And if WHO is kind of custodian of that at the moment, then mentioning about the financing and the transfer of ownership is one thing I think which needs to be considered very closely, because how that handover happens actually in practice is what's going to really determine about how the motivation is received by the government, and who is taking up who actually feels that it's them owning it within the government, which actual people. Some last comments from Moy.
Yes, thank you very much, Chris, for the last point you shared. I think, yes, I really like the term living guidelines, and transferring that new evidence knowledge to the government should be done really carefully. But I think that part can be done in more systematic manner if we can develop ICT system that include computerized, how can I say, algorithm that sets some criteria to choose what recommendation is fitting to this the context of Laos. So that, how can I say, the communication between WHO and the government can be developed and also to be evolved into a more systematic manner. So I think today's session is running out of the time. So I really appreciate the discussion and idea of that, and our team will think about that, how we can put into more concrete system. Thank you.
Thanks very much, Moy. Look, I hope that this has helped for at least 2 things for Moy and the team in Laos, of stimulating some thought about where to be investigating next. What are the themes that need to be closely considered when determining if ICT, if ICT is the best platform to move forward, then these are these little themes, these little topics that it's kind of like the health system building blocks, the governance and the financing, and how these all fit together really need to be understood. And for the audience, I hope that this has given some insight into the very start of the process of the innovation and discussion, that we started with one problem, one single problem that was posed by Moi, and breaking that down into different components, the key questions, and coming up with hypotheses about who are the end users, how is it going to be financed? And then this, a good example is this hypothesis that reporting issues will, the dissemination of data towards the users and the leaders is going to build some motivation to be able to update that from the government further. Were I more responsive and were I more organized, I would have this laid out a lot nicer. But the good thing about having this stuff in front of you is that you are able to move things around. And if everyone has the control over the screen, over this visual, then everyone's dynamically working on things as well. It's really productive for innovation that to have this live discussion happening. And I think that unless anyone wants to throw in anything else really urgently, then I'll wrap up the session there. I'm very grateful for the innovators taking the time, and also for Moi having the input and joining in the discussion at the end. So thank you very much, and I'll look forward to the next sections. Handing over back to you, Dr. Gordon.
Thank you, Chris, Moi, and innovation partners. This was not an easy session to manage, and you have set a very high standard between you. We deeply appreciate the willingness to participate in an open discussion rather than in a series of scripted presentations. Also, for you to have participated in a session intentionally designed around dissecting a problem, a real problem that is faced by one of our member states in Wipro. And these three problems that we are looking at are not theoretical problems. They are real problems that are being faced in a very practical setting in our member states. And they are ones with which we would hope as WHO Wipro to engage, not just in this session, but in a continuing, a continuing process. The discussion in the Q&A session has generated a few resources that I would recommend to our participants to visit on the side for anyone who is interested in solving problems of this nature. And this will all be highlighted in the report that we will produce later. To our colleague and friend, Dr. Sally Fox, so good to see your name appear in the Q&A section. You have raised a more general question that we will weave in to the discussion at another point, and I'll add a few responses in the Q&A section. I'm going to commit heresy and cancel the mobility break. So thank you all for that. So we will go straight, if we can, in order to catch up on our overrun. I give a virtual applause to all the participants in the first problem-solving session, and we look forward to our second one, which looks at a deeper stage of the innovation process. This problem statement is about cervical cancer elimination, and our moderator is Dr. Van Thi Thuy Nguyen from a technical officer within WHO Vietnam.
Thank you very much, Gordon. Good morning, everyone. First of all, I would like to say congratulate to all of our winners. It's very exciting today to hear all of the winner, a lot of diversified, innovative idea in the region. So to start with our panelist discussion for our group today, I would like to introduce our panelists. First, I would like to introduce Professor Valerie Fechin, the Director of National Institute for Stroke and Applied Neuroscience, Auckland University of Technology. Our second panelist and innovator, Dr. Sari Dawson, Research Director, the Fred Hollow Foundation, Australia. Our third innovator, Dr. Jing Li, Research Director, National Clinical Research Center for Cardiovascular Diseases, Chinese Academy of Medical Science, Fuwai Hospitals, China. We also have Ms. Dorothy Colt, CEO and founder both, MD, it's an innovator. Professor Winnie So, the Nether Shore School of Nursing, Faculty of Medicine, the Chinese University of Hong Kong. And our last but not least, Mr. James Galway Tan, Executive Director, Health Future Foundations. And I'm Dr. Van Nguyen, who will be honored to be a moderator for our session today. Very nice to see all of our panelists and innovators. Now, before we start with the discussion problem solving session, I would like to invite Chris Smith, who will share with us the problem for our group to discuss. Chris, please. Chris, you are muted.
I've just seen that. I hope that you're seeing my screen correctly.
Yes.
For whatever reason, I can't. In any case, so very briefly, sorry that you have to put up with me again. The problem that I've put forward to this group is about HPV testing in the Pacific Island countries. Some of you may know that there's been a big push supported by the WHO for elimination of cervical cancer. And we have published and promoted the global strategy to accelerate the elimination of cervical cancer as a public health problem globally. There are a set of targets inside here that need to be achieved by 2030 and maintained for the next 100 years in order to be able to eliminate cervical cancer. It's a big thing because it's the first non-communicable disease that could be eliminated. One of those targets, though, is particularly tricky. It's that 70% of women are screened with a high precision test by the age of 30, I can't read it in the small there, 35 years and 45 years of age. So very particular, and the keywords are there, high precision test. At the moment, there's only one of those, and that's called HPV DNA testing. The machine that does that is shown there. That this is one particular brand. There's several brands, but this one machine is the most prevalent throughout the Pacific Islands. Most of the countries have a number of these in country somewhere. And thanks to COVID, among many other things, there's now a lot more of them than there used to be in the Pacific Islands. And they're spread throughout the Pacific Island countries around here. And they're also available in New Caledonia and French Polynesia, where WHO doesn't actually have a lot of communication with. It's mainly these countries in green. So the good thing about the actual machine is that it can test for many different diseases, viruses, and COVID-19 has been the most problematic recently. But it does require these consumables, little blue cartridges which are quite expensive. And compared with the other tests that are currently available, HPV DNA testing comes out as being quite outstandingly much better than the other options, which are more suited for low resource settings. However, HPV DNA testing is the only way to eliminate cervical cancer, but it's very expensive. So this is the problem that I've posed to the team, and I look forward to hearing about how we can make this more accessible for the Pacific Islands. Thank you.
Thank you very much, Chris. Now, I would like to invite our panelists to share their innovative idea to support our member state in the Pacific Island countries, how to improve or accelerate access to HPV DNA for cervical cancer, so that we can achieve the global target of elimination of cervical cancer by 2030. I think it's not an easy task of looking at the different angle of the problem and propose the innovative ideas. But I would start with Dr. Winnie So. I see your hand, please.
Okay, thank you, Dr. Wen. And I think we need to look into several issues in order to support the government to achieve the global strategy target. So first of all, as what Chris mentioned, is the resources implication, including the financial implication, as well as I think it's the manpower resources as well. As although HPV test is a more sensitive and effective approach to detect the cancer screening, but you can see the cost is triple than the other one that we currently use. So I think the finance issue we need to tackle. And the second one is regarding the manpower resources. Now, and this is a kind of the training issues. This is the practice not commonly used. So we need to prepare a group of the healthcare providers in order to equip themselves to achieve the goal. The third one is, I think we need to target those eligible women for behavioral change, because this is a new approach for receiving the screening test. So I think we need to think several strategies in order to tackle all these issues in order to achieve the target of the global strategy for eliminations of the cervical cancer.
Thank you very much. So I understand that you propose 3 aspects to improve, to accept the HPV screening. First of all, that is the financing resources, where to get the result for make sure that the test is available and affordable for the people in need. And second is training the capacity for health staff. Even though it's a POC, it's a simple, it's a point of care, but still need the people to be trained to operate the machines. And the third is that our women who we are serving, make sure that they understand and they can change their behavior and also accept to the available testings. Thank you very much. So I see Mr. James Gamberton, you raise your hand, please.
Yes, good afternoon or good morning, wherever you are. Thank you so much. I know we have discussed this earlier, and I recognize the original idea came from Professor Valerie. Hello. Because as we are talking about sustainability in terms of funds, and I think for me, well, Dr. Valerie, I know it came from you originally. I'd like to acknowledge that about using alcohol or tobacco tax for financing health, particularly in terms of HPV or cancer. And of course, for me, the priority there is for leadership and governance, which means that in the countries where there is a high cancer rates, I think with the leaders of the country need to be aware of the importance of this test to be available to as many women as possible. And that could only be done through a financing by the state, either by allocating funds, definitely if they're and they allocate funds only if they're convinced that it is a problem. So that needs a lot of advocacy. And the other one, if there is really no funds, then what Dr. Valerie or Professor Valerie has suggested, that I know it takes a long time in the Philippines. I just like to say by our parliament or Congress to be used only for universal health care. And usually what has happened, while we do have the funds, the problem now is our Ministry of Health or DOH is unable to utilize fully these funds. I'd like also to put that into its own area. So I'm addressing the area of leadership.
It seems like we have a little bit of issue with
in terms of sustainability. Yes. Thank you.
Thank you very much, Mr. James Gamberton. Yes, Mr. Tan was talking about where's finance or funding come from, as he proposed by Dr. Gwyneth So. So one of the proposal from Mr. Tan is, and also initiated by Professor Valerie before, that we can have a strong advocacy to the government to ask for the tax. But they would say, you know, taxpayer actually spending for a lot of health problem, not only cervical cancer. And other thing we can propose, that is a alcohol and tobacco industry tax. And this need, of course, you know, a lot of strong advocacy to the government, high leader government, and also Congress, Assembly, and it takes time for us to make that, but that is one of the important to go. And that is a sustainable financing for the cervical cancer screening. Thank you very much. And I see Professor Valerie Ferrin, please, I see your hand.
Yes, thank you, Juan Nguyen, and thank you, Jamie, for commenting on that. I think raising taxes is not just for funding those screening or other health-related problems in the country, but it is, by per se, is for improving health of the population, because taxing on tobacco products or alcohol, unhealthy foods, but by definition, and the evidence is overwhelming, will improve health of the whole population. So it's just a matter for the government to be transparent about where these tax incomes will be directed to. If those tax incomes or revenues will be directed toward health of the people of the country, I believe most people would agree with that, because everyone wants to be healthy and live longer, quality life. I think this message should not be missed. It's not just for raising taxes, it's for improving health of the whole population. And the other comment I would like to make about these screening programs from epidemiological perspective. The screening tools, ideal tools, should have high specificity and sensitivity. And from the slide just presented, the most expensive one lacks a sensitivity, but it has very good specificity. And I think a combination of the cheaper screening tool like visual inspection with the DNA testing would be the best combination. That's just my suggestion. Thank you.
Thank you very much for proposal idea, Professor Valerie Ferenc. Yes, I totally agree that if we only talking about cervical cancer, maybe we couldn't receive the strong support. But if we put that in the health at general, especially for UHC, other diseases, they also request for the alcohol and tobacco industry to provide funding and for the screening and treatment, for example, like lung diseases or cardiovascular diseases. So if we put that in the broad picture, maybe we can have a more strong support from government and National Assembly, for example. Yes, please, Dr. Winnie So. Yes, I see your hand.
Yeah, and actually, I totally agree with Professor Fagan and also Dr. Tan about the emphasis of promoting health rather than, just compensate those health being damaged. And I think it is also echo from our keynote speakers. We need to change people's mindset. We are now looking for health, not for managing disease. So I think changing the mindset and align with all kinds of the governance and the policy is very important. So for example, for the health insurance, so nowadays we are now compensate those cancer treatment, but not the promotion as well as the screening. So if we can tune that mindset to put more resources for the cancer screening or promote health, so I think it can also align with our global strategy target.
Thank you very much, Dr. Winnie So. Yes, so I now hear another resources for financing for cervical cancer screening is that we can use health insurance. Now I understand that in some countries, health insurance scheme is only covered for treatment and diagnosis, not screening and prevention. But we can start advocate, promote it, that preventing is better than treatment. They can save a lot of financing budget if they spend for screening rather than spending for treatment. Treatment for cancer costs a lot of money, but screening, for example, for cervical cancer, it's cheap. As we see, let's say $15 for HPV DNA test, for example. So that's another door open for us to think how to advocate for health insurance to pay for cervical cancer screening, as well as other health promotions. Anyone else want to share the idea, innovate as an innovator? Dr. Jing Li, please.
Yes, I think I agree all the innovative suggestions. Yeah, and I also think about from the human resources that maybe we can encourage that women to be volunteer to do the test, to receive training, essential training, and do tests, and to organize, to do the education, etc., so that we can save this money. And also because women, they are the people who benefit from the screening program. So they should be more enthusiastic to do this work, and they can have a great impact to their friends, to their and to make the people from community to acknowledge, to appreciate the screening, and so that to make the best use of the screening, not to waste any resources. That to just to motivate people to receive screening earlier, and so that you have the so that just pay the small money, a small amount of money, and to save the many of the future expensive treatment. Also for the insurance, I think that there's also a similar way that if the people encourage people to receive screening, and so they can get higher proportion of just to use lower proportion of out-of-pocket payment for future treatment of cancer. Yeah, maybe that's a policy should be leverage that policy to encourage more people to be involved in the screening program, so that also save money. Yeah.
Thank you very much, Dr. Jinli. Yes, powerful women, powerful community, that also very important aspect. They need to know the need and also benefit of cervical screening. So we can have a different idea how to promote and how to make sure that our women understand the benefit and also initiate active in terms of taking the screening test, and also spread the information or educate the community to understand and get the test earlier. Thank you very much, Dr. Jinli. Yes, Dr. Sanity Dawson, please.
Hi, everybody. Thank you to the panelists who have already spoken. I agree with many of the points that have been made already. Two points from me. I just wanted to reinforce the point that Dr. Winnie So made at the beginning, just around the multi-faceted nature of the problem and the need to really understand the problem from a macro point of view as we then move into trying to innovate at the more micro level around particular aspects of that problem, because we may find that we kind of solve for one aspect of the problem and that leads us quickly into hitting other aspects. So what I mean by that is we may solve for the cost issue and therefore make the screening more available to women, but we may find that women aren't aware of the need or the availability of the service and therefore aren't accessing it to the degree that we might like. So I think we need to first take a macro view of the problem and understand each of the elements that we need ultimately to innovate around, and understand that it's probably a long-term undertaking to ultimately solve and eliminate the issue that we're trying to solve here, but we can make gains in particular areas over time. And just to hone in then on that issue that we've been discussing, particularly the cost issue, we have been talking mostly about the side of the problem, which is how do we cover the cost? I think the other side of the problem is how do we reduce the cost? And there's opportunity for innovation around that. There may be a way that we can bring down the cost of the cartridges. How might we go about doing that? There might also be a way to reduce the cost impact on countries by, for example, pooled procurement across the various countries. So I think there are multiple ways that we can perhaps address the issue and the different components of it.
Thank you very much, Dr. Dawson. Yes, Dr. Dawson touched in another aspect of the resources for cervical cancer screening. That is not only where the funding to cover the cost, but how we can make the cost reduce or lower so that the people can be more affordable to the tool. So at the CRISPR in the Pacific Islands country, we have some opportunity in terms of reducing the cost. That is already existing pool procurement mechanism for vaccine for other cartridge, but we can also add the cartridge for HBV DNA into that list. And we need to make sure that supply management is sustainable and functioning well, so that we can negotiate with the manufacturer to reduce cost. So that is a really important aspect. And also I hear that Dr. Sariti Dawson also mentioned a new aspect. That is that if we make the tests available, affordable, but people don't come for the test, then the issue here is that raising awareness, how to make sure that the community, our women, our girls understand and come forward for the test. So raising awareness is also important. We need to go on these things together, not just only financing or only costs, but we need to take on the aspect of this problem together. So anyone else to say? Yes, Mr. Jim Gavitan, please. I see your hand.
Yes, thank you again. I'd like just to address that issue of demand of women for the test. And the way we'll do it in the Philippines is we have what we call village health promoters. So these are volunteer women also in the community who are given additional training to promote health, meaning to say to encourage their fellow women to come and be screened. Now, part of the Philippine landscape also in terms of communities, we have village health workers. No? So we have two different kinds in our program. We have health promoters who are dealing with the prevention and the promotion of health behavior change. And we have village health workers that are part also of the health system, but very few compared to the village health promoters. So with this, we're able to mobilize the whole community to be screened, particularly for, well, in our case, non-communicable disease, but here in this particular case, to the extent that it can be done in the Pacific Islands. Well, that's my suggestion. Thank you.
Thank you very much. Yes, I think that's a very good idea to have a champion, especially from our women, from our community. It's an example from Philippines that we can have a promoter, health promoter, and they are not only promote for cervical cancer screening, but they may be already promoted for different disease aspect like diabetes or vascular diseases. And now if we change, they can be our champion to promote for cervical cancer screening as a community. Yes, I see Dr. Jingli, hand, please.
Yes, yeah. So just regarding how to promote the understanding of the importance of screening, I think that we can use to make some videos with the format of cartoon or the real person story, the patient story, and the patient and their family can tell their story, and some other formats, and to be broadcast not only in the TV, in the mobile phone, the internet. Also, we can use the existing club, any social club, not only club of women, but also men, because husband should also support or maybe to suggest, to advise his wife to go to attend the screening, so that use all the available media to promote. Yeah.
Thank you very much. I like the idea that not only introducing a very good key message, but we use different tools like a video or infographic or cartoon. But the thing I'm really like is that we are not promoting women only, but we need to promote men as well. I think men are powerful, the head of the household. They can, advise their wives to go for cervical cancer screening. Thank you very much. Dotco, please.
Sure. So I think, it's a very good discussion, because one of the things that I always believe is that when you look at countries and you look at the way that information spreads, how do you leverage what has already been done? So one of the things that has been very, common in these days is actually COVID, right? COVID, everybody looks at the news for COVID. If there's a way that we can actually tie this to, COVID vaccination or information that's actually disseminated, that would be a really nice way to actually bundle it. The second thing is actually, if you look at the young, most people are actually on tech platforms, right? Social media. If there's a way that we can actually, create videos, campaigns to actually encourage younger women, because younger women have a role to play as well within the house. So this is something that I believe, the more that we can actually use what's already there and actually amplify that, that would be a goal.
Thank you very much. Yes, we can take some lesson learned from COVID, where we just, still not only past, but still ongoing. We have a lot of demand creation and information sharing and communication campaigns that we can learn and apply for our message for cervical cancer screening as well. Yes, I see a hand from Dr. Winnie So and then Dr. Sariti Dodson. Dr. So, please.
Okay, thank you. So I'm just thinking about although we need to look for the resources, for the tree test and also to reduce the cost as mentioned by Dr. Sariti. I'm also thinking about, don't forget about the existing resources in community and how to make good use of our existing rich community resources to achieve the goal. So I think one of the issue is just echo from Dr. Jimmy, the community health worker in the village. Although they may not promote the cervical cancer screening, but they already in place for the health promotion related roles. So if, for example, if the government or one of the countries already set up the maternal and child health care system very well, so actually all kind of the healthcare provider for this aspect already in place. And what we need to do is to train up them and integrate the HPV test in place in order to speed up the process of increasing the screening uptake. I think for the assessment of the community resources is very significant, and how to make good use of the existing resources in order to speed up our target goal.
Thank you very much, Dr. So. Yes, we should take advantage of existing resources to make our proposed plan more sustainable. And one of these proposed by Dr. So is that we can use the MCH system currently, cover from national level, provincial level, district, and community, so that we can build up their capacity and using them to promote for cervical cancer screening. Thank you.
Yeah, in particular, they are targeting our eligible women, or the young women.
Yes, more targeted and more prioritized population. Thank you. Dr. Sariti Dodson, we want to hear from you.
Yes, thank you. You're just picking up on that last point actually about targeting. I think one of the features of this particular challenge or problem is that we are trying to engage women of a particular age. So it's not a whole of population challenge. So that opens up some unique opportunities. How might we identify the particular women that we want to engage and be very targeted in our approach? I know, for example, in Australia that breast cancer screening is very targeted. So women receive a letter in the mail when they reach a particular age, and that database is generated from the electoral roll. So are there ways that we can identify very specifically the women that we are trying to target and reach out with a personalized approach? A letter is perhaps one way, but we would need to identify what would be appropriate in the particular settings. And the second point I just wanted to make was we've talked a little bit already about the need to raise awareness amongst the target women, but I think we also need to understand what might be why women might be hesitant to engage, even if they were aware of the importance of the availability of the service, what might be creating some hesitance amongst them. And so you could, for example, if you were taking a targeted approach, use that as an opportunity to collect some information from those women about why they may or may not respond to that information that you've provided, and that provides you with information that you can then use to inform the next iteration of your strategy to engage them.
Thank you very much, Dr. Dodson. Yes, again, we hear that we should be targeted for the women that need to be access to the cervical cancer screening. And this is even more important within the limited resource setting. That we don't have a lot of resources to cover for all the populations. At the same time, we also need to think about how to support for the women who are maybe have hesitancy or maybe barrier to access to the screening test. So I think within demand creation, promotion, or if we can have a particular research to identify the barrier of the women not accessing the test, that also can help it where to intervene, what interventions would need to open the barrier for the women. Thank you so much. I think a lot of idea in the solution proposed by our panelists. I would like to ask Chris, who's giving us the problems, and he have observed on the panelists discussion and sharing ideas. Do you have any thought to share with the panelists?
Yeah, look, that was really interesting discussion to hear through how people are thinking and the different ways of approaching this problem. I was halfway through a long post by someone in the Q&A, which I'll have to get back to in a moment. The thing which struck me is that there's this dichotomy about the supply side and the demand side of being able to provide a service that people are talking about here. And that there's lots of talk about increasing the demand side of the service, that getting more women to take up the cervical cancer screening so that governments and agencies realize that there's a great need to actually provide, to supply the HPV cartridges, which is great. I think that it's a careful balance, because the more that is emphasized, then there's less women who are able to actually receive the service. All of them might want it. There's less of them who can receive it when it actually comes to that. And so the rest who don't receive it are put off, and they don't come back to the screening then. This is something we see more in the treatment aspect of cancer. But if the screening isn't there, then people won't really be bothered going back. This is, just something that goes through my mind. But there is a lot of power in the community, and that's true. There was mention of pooled procurement, and actually, I think even just since we have been talking through this this problem in the last week or two, that has actually, we've started doing that to an extent with the supplier and trying to figure out what the landscape is in the Pacific Islands to be able to negotiate that. But the thing to realize is that all the Pacific Islands are very different, that in some of the countries, taxation could work, and then that would improve the financing. In other places, that's just going straight to the entire government budget, and the Ministry of Health gets exactly the same, no matter what. Some places have lots of resources at their fingertips, and other places really don't have the networks, don't have the ability to reach down into the community level. One of the last things that was mentioned was about personalized reaching out to people. There are technology obstacles in the way in the remote areas, but I still think that's something really good that we should be pursuing further, maybe with mobile technologies, which has some good penetration in the Pacific Islands. So thank you very much, everyone.
Thank you very much, Chris. And I see Dr. Gordon Gali, you raise your hand, please.
Indeed, there is a, thank you very much. Again, a very active discussion, maybe compensating for the lack of a mobility break. But I thought I might pop in and summarize a few points that are being made in the Q&A section, just to contribute to this discussion. So there's this open question that's been asked by Sally on equity, and there have been a number of points made both by the panelists as well as by the discussants on the Q&A section about using various forms of payment, such as including the health promotion or sin taxes, including this intervention in universal health coverage benefits plans and covering the HPV testing by national health insurance, reaching rural and poor women through innovative modes of delivery. I would like to add here that one of the innovative solutions that made it to the shortlist but did not make it, unfortunately, not everyone can win, but did not make it to the list of the winners, is one in which groups of rural and poor women in the local community are brought together and taught how to do self-swabbing in an interactive session, which handles 10 to 15 women at a time in multiple groups in succession, reducing very much the collection cost, not so much the cost of the test itself, but as a means of increasing coverage and equity. And of course, this team has covered the combination of more expensive modes of screening HPV with the cheaper ones, such as visual inspection with acetic acid. Eric Rafai has made a strong point about this package of combinations should be delivered for the Pacific Islands when based on an understanding of the epidemiology of cervical cancer, noting that the existing systems for data collection and collation are generally limited and still under development. Numerous comments made a point about the importance of call and recall systems and the targeting of screening to ensure that all women who are eligible are covered. We know very well that purely opportunistic screening is not enough and will not result in an impact. Other points were made about capacity, so that apart from the financial cost, the importance of training the grassroots healthcare workers in the recognition of people at risk for such cancers was made. Also by Mark Rife, a bit of lateral thinking. Are there ways in which cervical cancer programs, he asks, could be connected to programs for maternal and child health, given that there's an overlap in the population, the catchment population. Of course, already Chris in the problem statement itself showed how that the technology for doing HPV testing is already taking advantage of another health condition, the spread of COVID, and the availability of PCR and NAT testing is now prevalent across many countries and regions that did not have these technologies, and therefore one area of public health has been led to positive developments in another area. The problem statement is very good. It is one that focuses on the themes of reaching the unreached as well as non-communicable diseases, and puts us in this space of discussing the optimal use of scarce resources in the Pacific and overcoming the technology divide at the same time. There are other comments that I have not had chance to integrate, but I hope that this gives at least a flavor of the discussion that is happening on text. back to you.
Thank you very much, Dr. Gordon Kali. And thank you so much for sharing with us a lot of ideas and comments from our participants, which is some, adding a new idea to our discussion, but also consensus with some of the idea raised by our panelists. We have a couple of minutes left. I'm wondering if you have any burning idea you want to share? Yes, Dr. Ringley, please.
Yeah, I also have another two suggestions to reduce cost. One is to increase the funding that we can make advertisement that some company can, we can give them advertisement at the screening site so that to raise the foundation. Another is to reduce cost, whether we can consider mixture that several people, that the several samples mixed together for the screening, because the maybe it's only a small part of people is positive. So we can use a 5-to-1 mixture so that to decrease the number of tests to reduce the money. And if found positive results, we can do the further individual test. Yeah.
Yeah, thank you very much. Any panelists want to raise the final idea solutions? Yeah, Professor Valerie, please.
Maybe it's a crazy suggestion, but I know from colon screening in New Zealand, for example, we use a tool that sent out by mail to the people aged over 60. Maybe we could suggest something for smear tests for women, because this way the cost of attending physician for the examination is reduced enormously, and the acceptance of these tests results could also be mailed out in the pre-posted envelope is also quite high in New Zealand. Maybe I'm not specialist in that screening test.
The Bluetooth device is connected successfully.
Sorry, what
yes,
was
please.
that?
Yes,
Yeah.
Please go ahead, Professor Valerie.
Yeah, that suggestion, develop something home-based, simple screening with sufficient sensitivity for detecting cancer, and then do more sophisticated and costly tests later on for selected patients. And the other suggestion which I would like to air is that I think it is important, while addressing specific health conditions like cervical cancer or whatever, it is also important to exercise a holistic approach to the health and try to implement measures which has a broader effect on the health of the population. Like, again, that taxation, that's where the money could come from, and this sort of population-wide prevention strategies. I think that's the way forward for the future.
Thank you very much, Professor Valerie Ferrand. Yes, I would like to give our last opportunity for Chris. You raise your hand, please.
Yes, thank you. I hope we've got time, and I'm very grateful for everyone's input as well so far. So there's excellent ideas, and I want to point out that there aren't any crazy ideas, Valerie, and especially in innovation. There's not such thing as a crazy idea. But I'm wondering about the mail outs. That's also been tried in Australia with varying success. I'm just not sure how it would work in the Pacific Islands, where it's difficult to move things around, ship things around, and keep them of adequate quality. Excuse me. And then something else which has been coming up is about kind of risk stratifying the women and targeting particular subpopulations. The WHO guide does have guidelines about which women to target, what age ranges should be given what types of procedures, and in different resource settings, what is the correct algorithm for different high resource or low resource techniques to be used. So we do have things like that. If it's evidence-based in each country, that's fantastic. Although it does raise issues about equity and inclusiveness. I don't think we're even at that stage to be concerned about that yet. For this problem, we just need the women to be coming in. And again, we need the cartridges, the consumables to be there when it comes to the lab. But thank you, everyone.
Thank you very much, Chris. I think we still have a lot of ideas to share, but our time is up. So I believe that we have a very active, productive discussion from our panelists. And we were talking about, how to help our Pacific Island country to reach their elimination target for cervical cancer, with different aspects, different idea from financing for the test, from taxation, from reduction of the cost using existing mechanism to make sure that it's sustainable. We also need to make sure that our community, our women are aware of the test and active and go forward for the test. We have a different idea for health promotion, including our cervical cancer screening. So I would like to take this opportunity to thank you very much to our panelists. The contribution today is really valuable to help our member state to achieve the target. I understand that there's a diversified health system structure in the country, but we don't have any tool to fit all of the country. But each country can consider their existing health infrastructure, and also health, human resources, and whatever mechanism, political commitment as a country, so they can apply this innovative idea to go forward for elimination of cervical cancer. Once again, thank you very much for the idea. We will see you again in the summary section. Thank you.
Thank you.
Thank you, Van Yen, for moderating, and Chris for reappearing in the new role of problem statement, as well as to our innovators. Again, big congratulations for your award. Answering one of the questions in the Q&A, if you want to know more about the innovators, the website that has been linked in the chat has a full list of the innovators, and each of the innovators has their own dedicated page where they describe their solution, and a longer video than the one you saw earlier. So I ask Jisuk, who is one of our team, to kindly re-enter that in the chat so that people have an easy way of seeing the great work that you have been doing. In a partial answer to Sally's comment about the management, the commercialization of innovations in health, we will now move on to a video address by Dr. Liza McDonald from the University of Texas at Austin, as well as a co-founder of the new Global Health Security Fund. She will describe the process of incubation, that is a process of taking an innovative idea from idea through to deployment, and with all the processes in between, including investment as well as mentorship among other services. So I ask the technology team to please unleash Liza.
Hi, my name is Dr. Lisa McDonald, and I am the Director of Healthcare at Austin Technology Incubator at the University of Texas at Austin, and I'm also founder and managing director of the Texas Global Health Security Innovation Consortium at UT Austin. I'm so pleased to join you here today for a brief discussion about creating healthcare startup incubators. So in my role at both TexGHS and Austin Technology Incubator, I'm responsible for the incubation of healthcare companies, startup companies. At ATI, we've been around for 30 years. We're one of the oldest and longest running university-based startup incubators. And over that period of time, we've learned a lot of very important lessons about what it takes to spur economic development, especially in the Central Texas area. So ATI works with startup companies. We are part of the University of Texas at Austin, but we have a unique position interface between university researchers and community entrepreneurs. And once those community entrepreneurs or university researchers are ready to start a company, to form a company, they would come in and apply to ATI and come through our series of different steps to become a part of the startup incubator. And what does that mean? Well, oftentimes we work with startup companies that are early on, maybe they've just formed, maybe they've received some non-dilutive funding from different entities, and they're looking for steps to advance the commercialization of their device, diagnostic, digital health and telemedicine tools, therapeutic, a wide variety of different technologies. And so they will stay with us at ATI between the time that they formed a company and they were able to receive a Series A capital raise from an investor. And so that's really our sweet spot. And ultimately, that's a very, very important spot in any company's life cycle, because during that time, they're having to traverse the valley of death. So a time when they're between proof of concept funding and investor funding. So we assist companies during that very, very critical time, make sure that we can support their commercialization activities. ATI has rolling admissions. So you're probably familiar with different accelerators where you bring in a large cohort of companies or even a small cohort of companies. And over the course of 3 or 4 months, they'll go through some basic entrepreneurial training. And at the end of that 3 or 4 months, they'll graduate from the accelerator and move on to the next thing. For ATI, we have found success with a longer term engagement, and we utilize rolling admissions. So we're always evaluating companies for whether or not they would be a good fit for the incubator. It's a highly selective process, and we generally get, we'll have companies that come in through word of mouth. Obviously, after a long track record of helping companies, we don't have to advertise as much anymore, but that's a pretty important thing, especially if you're early in setting up a healthcare incubator or accelerator. For us, we have found the power in word of mouth and then some limited marketing and advertising can be very, very successful in getting that pipeline of innovators. So how do we help companies? For the most part, companies' experience with ATI is very customized to where they are in their stage of development. We work with 2 different portfolios. We have a sustainability portfolio of climate-based technologies that are looking to improve clean energy, circular economy, and those things. And the other half of the business is working with healthcare companies. And so we customize our approaches because each different company, even within portfolios, has different needs. They'll have different regulatory requirements. They'll have different legal requirements. And so it does require a customized approach. The way we deliver that customized approach is largely through a volunteer mentor network and mentoring for companies, where we'll assign 3 or 4 mentors to each individual company, and the company can utilize those mentors as an ad hoc advisory board. The reason I mention that is because assembling a mentor network and assigning those mentors to early stage companies is something that you can do regardless of how well resourced your setting is. And so that's a very important first step that you can take in building out a large mentor network, so you can then use that engine of expertise to put behind startup companies that you're assisting. There's plenty of other ways that we help startup companies, that we help member companies. They can be directly through us or through tapping that network of subject matter expertise, or working very closely with vendors and service offers to make sure that each of our companies, there's fewer steps and we can be a one-stop shop for innovation for them. We have a small portfolio of technologies within ATI. But in addition to performing work to assist startup companies, we also incubate ideas. One of the most important ideas that we've recently incubated at ATI is the Texas Global Health Security Innovation Consortium. TextGHS started in early 2020 as COVID-19 was spreading across the United States. And this was really designed to test out the hypothesis that the creation of an innovation ecosystem thematically around health security can benefit innovators that are working on COVID-19 related technologies. We've had a lot of experience with this and setting up and systematizing this approach to assist startup companies. Over the previous 2 years, we've received funding from the federal government of the United States to stand up this innovation ecosystem. And we welcome anyone with technologies that are related to health security, related to infectious disease, or related to recovery from the COVID-19 pandemic to seek us out, find out about the assistance that TextGHS can provide you to startup companies specifically, but also compare notes and compare best practices as we continue to build out our innovation ecosystem around health security. We want to work very collaboratively with people around the globe as they continue to improve their local contexts and local innovation ecosystems so that we can all work together to kind of improve the commercialization of healthcare technologies. I will stop there. It was wonderful to get to join you even briefly, and please don't hesitate to reach out to me directly for questions or comments about the presentation today. Thank you.
So thank you, Liza. And I understand from the Q&A section that you are actually signed in as Andrew. So people who want to reach out to you can do so directly and by engaging in the chat or the Q&A section. And Andrew, her partner in this work, will be appearing tomorrow at in one of the panels. So this is a little teaser for those who want to explore more this issue of venture capital, investment, incubators, and startups, want to hear about this process. We hope to draw you in tomorrow. I will now yield to a more mellifluous voice than mine. I hand over to Anna to bring in a bit of liveliness to our discussion on innovation. We now come between I'll just set the parameters between now for the period of the coffee break. So starting at 12:22, for the next hour or so, we will have a live band and a side event. And Anna will not only be entertaining us, but also emceeing the process. So over to you, Anna. Thank you.
Thank you very much, Gaudin. And thank you so much for having me to play some music for you this afternoon. It's a real pleasure. I hope you've been enjoying the sessions this morning so far. My name is Anna Smirk, and yes, I'll be playing some music for you for the next 10 minutes or so before the side event begins. The first song that I'm going to play for you is in fact a song that I wrote specifically for the forum, for this innovation forum. It's a song about innovation in public health. It's trying to highlight the importance of innovation in this field, as well as sort of celebrate the amazing impact that innovation can have on real people's lives. And the song was inspired, in fact, by the Innovation Challenge that we've been talking about today. I was shown a bit of a short list of some of the amazing ideas and the amazing solutions that were submitted as part of the Innovation Challenge. And I'm using them in this song, some of them in this song, as examples to really highlight and demonstrate and give a real picture of what innovation can look like and the important impact that it can have. So here is this song written for the Innovation Forum. I hope it serves to sum up and inspire you as to why we're all here at this forum. The biggest dream, the smallest shift, they ripple out and lift us up. The world is changing, we must create a healthy future. Water pumps that don't need power, for sanitation no matter where you live. A custom fitted lorry, providing eye care to the underprivileged. A health hotline system reveals potential epidemics. A smartphone application detects antimicrobial resistance. The biggest dream, the smallest shift, they ripple out and lift us up. The world is changing, we must create a healthy future. We gotta innovate. Predicting risk for heart disease, using algorithmic technology, social network messaging, promoting services for HIV, supporting work for older people, for independence and a more active life, games to change behavior, better eating habits, healthier diets. The biggest dream, the smallest shift, they ripple out and lift us up. The world is changing, we must create a healthy future. We are here to help you find, adapt and scale and redesign. The future's now, let's accelerate to a healthy world, because we innovate. Thank you. So that was the song written for this event in particular. I'd love to hear any thoughts or any ideas that have come up when you listen to that song. Please put them in the chat and let me know what you think. I'm going to just play one more song for you now before we hand over to the side event, to explain a little bit about who I am. When I'm not playing music and touring and recording, I work for WHO as a consultant in the Western Pacific region. I work in the communications division. And I've been very lucky to be able to travel to a lot of wonderful countries in the region as part of my work. And I'm going to play you a song now that I wrote in one of those countries. I lived for about 3 years in the Solomon Islands, working in the country office there. And I wrote this song about my time in the Solomons and learning about the culture and trying to understand really deeply that particular place. I'm going to start it off with a little bit of a song that I was taught by some friends of mine over there. I was very lucky to be able to play music with a lot of wonderful musicians in the Solomon Islands. And they taught me some beautiful traditional local songs and very, very generously gave me permission to share these songs and play them for different audiences as I play around the world. So I'm going to start off with a song called Kakabona, which is in Solomon Islands Pidgin. And it's a song about a beach called Kakabona, just near in the island of Guadalcanal. And I'll go straight from that song into my song that I wrote about the Solomons. O kalasilang umano-mano e mio penny me wantem baim sweetie melaki patuleti fomiku saritu masi one fala Sunday me go Sunday lo kakabona o kalasi lang umano-mano e mio penny me wantem baim sweetie melaki patuleti fomiku saritu masi one fala Sunday me go Sunday lo kakabona. Benjamin tells me the boat for the mainland comes at 5 or at 6 or 7, sometimes at 8. He says wait, and you'll see when it comes. The light starts to fade and he switches the generator on. Benjamin's Island is just 2 k's around, circled with mangroves and water like slow liquid glass. In the past, his great-grandmother swam these very same waters, and so will his children to come. Oh, it comes when it comes. Oh, it comes. Oh, comes when it comes. Hey, Benjamin tells me the name of the island means a break from the wind, a place to take shelter at sea. As for me, it's a port of safe call. I'm halfway across and I'm scared I won't make it to shore. Oh, it comes when it comes. Oh, comes when it comes. Hey, it comes. Oh, comes when it comes. Hey, it comes. Oh, comes when it comes. Benjamin tells me the boat for the mainland comes at 5 or at 6 or 7, sometimes at 8. He says wait. Thank you very much. That's all from me today. I'll be back here tomorrow with some more songs for you. I hope you're feeling energized and ready to go for the next item of the program, which is the side event on social prescribing for healthy aging. So I will pass over now to Dr. Sébastien Libert. Thank you.
Thank you so much, Anna, for those 2 wonderful songs. Good morning, good afternoon, and good evening to all of you. And thank you for joining us for the 2022 WHO Innovation Forum. This is the first lunchtime session on healthy aging. My name is Dr. Jason Ligot. I'm from the Mental Health Unit at the WHO Regional Office. And joining me here as my co-moderator is my colleague, Dr. Sébastien Libert, who's a consultant for the Healthy Aging Unit, providing country support on healthy aging. So today, we will be leading you through a series of entertaining and informative activities, which we hope will challenge all our perceptions about what it means to be healthy at all ages in life. We will also invite you during this lunchtime session to consider the very important role that our communities play in supporting a healthy and happy aging for everyone. And that segues very neatly into the launch of our new Open WHO training and toolkit to guide communities and societies in supporting health and well-being as we age. Now, our original plan was we actually invited a very dynamic personality to start off this lunchtime session. Her name is Nanay Doren, or Mother Doren. She is formerly a community health worker in the Philippines, but more importantly, she's actually a very, very famous influencer on TikTok with over 1 million followers. Unfortunately, Nanay Doren seems to be having some technical issues, but we hope that she will be able to join us maybe later on during the open forum. Now, what's interesting about Nanay Doren and why we wanted to invite her is that she's actually a senior citizen. And despite her age, she has found fame and popularity on social media with very wonderful dances, inviting her millions of followers to join her in being physically active. So she is such a great example that really at any age, not only can you be physically active, but you can engage with so many people in your community, beyond your community, through these different platforms. Now, we wanted to ask her rather to lead us through a series of just simple steps of physical activity. But since she's unable to join us at the top of the session, we wanted to play a video of what she was doing or what she does on TikTok instead, and invite everyone to follow the steps. Now, we did a practice session actually yesterday, and I was surprised to learn that the plan was for her to do this song. Now, if you're from the Philippines, you probably heard of Paru Paru G. Now, if you're not from the Philippines, let me give you a very brief orientation of what Paru Paru G is all about. It's something that's gone viral. It's one of those famous social media challenges that almost everyone is doing nowadays. I haven't done it myself, but now I guess there's a first time for everything. And everyone is just dancing to this song. It's such a catchy tune. Now, there are 3 basic steps. So let me walk you through it. So Paru Paru is, it actually means butterfly. So the first step is you put your hands over your chest, you cross it. Now, if you can do this sitting down, but if you want to stand up, you can do that as well. And I'm just gonna remind my colleague Sebastian to cue that video because I don't think I can do justice to what Nanay Doren does on TikTok. But you put your hands over your chest and then you motion like this, so like a butterfly. And then you start to move and you feel the music, and then you extend that to your hips, and then you move up into your head and then over your head. It's very, very simple. People are doing it, children are doing it, older people are doing, everybody's doing it in the Philippines. So now you'll get the chance to see what this video is all about. So I'm just gonna check in quickly with my colleague, Sebastian. Sebastian, do we have that video queued up?
Yes, I can show it now. If you
Okay, wonderful. So let me just stop sharing this slide right now and turn it over to you just so that we can quickly show that video. And hopefully, as I said, maybe Nanay Doren or Mother Doren can join us later on in the Q&A. There you go. Okay, so actually, this is Nanay Doren. And we were practicing this yesterday, and I was just thinking that, gosh, even sitting down, you can break a sweat with that dance. So hopefully later on, she'll be able to join us. But yes, she's such a great example of what it really means to be aging, but in a very healthy way. As you can see, she's dynamic, creative. She's using this platform on TikTok to engage with so many people and inspire people of all ages to be physically active as well. So now, on that note, we're also very pleased to and very honored to be joined in this lunchtime session by Professor Melody Ding from the University of Sydney. So Professor Ding is actually a epidemiologist and behavioral scientist who's very passionate about behavior change and also the benefits of physical activity, especially later in life. So Professor Ding, thank you so much for joining us for this lunchtime session. We're so excited to hear from you and to hear your insights about physical activity and why it's important for all of us, really, not just as individuals, but as communities, to encourage everybody to move more. So Professor Ding, over to you.
Thank you so much for having me. It's really hard to follow the
I know, isn't it?
This is the most fun forum I've been to. You've got singing, dancing already happening.
We're engaging
lunchtime.
all the senses today.
Yeah, fantastic. I'm going to encourage everyone during my talk, only 10 minutes. Feel free to move. You can continue doing the butterfly dance while listening to me. All right, I'm going to share my screen.
Okay.
Thank you so much for having me. I'm really excited to be here to share with you my passion, not only in my work, but also in my personal life, that is physical activity. And I've already got a little footnote for you. There could be some myth busting involved in my presentation today. So my name is Melody Ding, as just introduced, and I'm really looking forward to connecting with you through this forum and after. If I could give you a magic pill, and I tell you that by taking this pill, you will reduce dramatically a lot of chronic diseases. You can sharpen your brain, you could, feel better, you can live longer, less likely to die, everything. How much are you willing to pay for this pill? I'm sure a lot of you guys are ready to line up and ask me, where can I get it? How much? I don't care. But what if I tell you the pill is actually mostly free? All you need to do is to take that at some point every week. That's regular physical activity. What would your reaction be? Are you going to be the one who says, oh, fantastic, I can't wait to start right now? Or you're going to be the, I know there's going to be a catch. There's never a magic pill. All right. I have heard a lot from friends and families who are not as active, and I've heard it all. I can guess what you might say. So throughout my presentation, I'm just going to bust a few myths that I hear a lot, or excuses that I hear a lot from people who are not willing to be active. First, you may say, exercise. I'm not a sporty type. I don't like exercising. Good luck getting me out of this couch. Then I would really like to redefine exercise for you. We might think of exercise like what you see on this picture, this determined, very fit looking young woman going for her morning run. Sorry. The reality is sometimes exercise might take in a form that is less planned. So physical activity is different from exercise. Exercise means that you're exerting physical activity for the purpose of fun and health, but physical activity can really happen in an incidental moment throughout our life. It doesn't have to be planned. It doesn't have to be done with the intention of increasing your fitness. So it could literally be running for the bus that you're late for. That short burst is also counted as physical activity. So let's redefine physical activity. It doesn't have to be exercise. It is just moving. Next, I often hear people say that I don't have time. We're all very busy, especially, a lot of the participants today, I can imagine. Can't you see how am I supposed to find time to do physical activity? Oh, well, what we often imagine is that we really have to set aside a set amount of time, given that's 30 minutes, an hour, and that is a large chunk of time out of our daily schedules to do physical activity or exercise. But the reality is more and more evidence is pointing that physical activity could purely be sporadic throughout the day. That's why I emphasize the importance of incidental activities. So it could be something that is less planned, but you can incorporate throughout the day. It could be 2 minutes at a time, 30 seconds at a time. It doesn't matter. It can all add up. It could be parking your car a little bit further away than you normally do so that you get 5 minutes of extra walking on each way. It could be getting off the bus a stop earlier. It could be replacing your driving with taking the train so that you have to walk to the platform. So all of these adds up. It could even be weekend warriors that unfortunately, if you're so busy throughout the week, you don't have the time, but then you go for a hike on the weekend. It doesn't matter how you accumulate physical activity. As a chunk or sporadically, they all count. You will also say that 30 minutes a day, that's what people usually think. 10,000 steps, Again, that's a myth. I'm going to talk about that later. Oh my gosh, how am I supposed to do that? So here, I think it's a good opportunity for me to introduce the WHO physical activity guidelines. So there is a magic number, so-called, of 150 minutes per week, but I need to just kind of start to dissect that a little bit. When we talk about physical activity, especially in the health context, we often talk about two different types of intensity. So there's the moderate intensity, which is what we're usually doing when we're walking at a relatively fast pace. Even if you walk at a normal pace at about 5 to 6K an hour, you're still almost at moderate intensity. Then there's vigorous intensity, that is like running, doing sports, playing basketball. So these, as you can tell, you get out of breath, that's vigorous. In terms of energy expenditure, there's usually a 1-to-2 ratio. So when you run for 30 minutes, it's almost as much as burning the same amount of calorie of walking for 60 minutes. So in terms of physical activity guidelines for the WHO, it's recommended to do 150 minutes per week of moderate intensity, which is 2.5 hours of walking throughout 7 days. That is not a lot at all. If you're really short on time, then you might consider doing vigorous intensity because it's more intense, you just need to do half as much. So this is really just an hour and a bit of vigorous intensity recommended every week. You can do a combination of both as long as you follow the similar kind of exchange ratio. So I put the link here for those of you who are interested in checking out the new WHO guideline. So this is numbered here. So you can tell that it's really not a lot of time. Like what I said, even 150 minutes of walking and 75 minutes of running, for example, doesn't have to happen on one day or in one go. So it's not that hard to do that. And in terms of steps, there have been a lot of perceptions about 10,000 steps. I actually don't even know where that came from. It could just come from some campaign for 10,000 steps a day. But my colleague and I have done a dose response meta-analysis on how many steps are really required to prevent early death. And what we found is that already at this arrow that you see here, about 4,000 steps, that is nothing. That is basically just basic moving around. You could already see that your risk for premature mortality decrease significantly. And then between 4,000 and 7.5, we see that there's a sharp decrease. With more steps you take, the lower chance of death. And further, you still see some decrease, but it has slowed down. So what we proposed is actually that if you can get to 7,500, that is already a substantial reduction in mortality risk. If you can reach that much, if you do something, it's better than doing nothing. In fact, these results really confirm all the current epidemiological evidence that the most important step that you take is the first step. When you change from doing nothing to doing something, that's when you see the most benefit, even if you don't get to reach the WHO guideline. All right, this is something that I often hear, especially from journalists. You guys are always changing the stories. Years ago, people were talking about this type of exercise, then it comes to high intensity, then people are talking about jogging. What exactly shall we follow? Yes, it is true. And especially if you also work in diet, you're probably also confused by all different kinds of recommendations for different type of diet that could be good for health. In terms of physical activity, what I can say is that we are currently constantly making progress in better understanding physical activity. So yes, there has been changes over time. For example, 20 years ago, people recommend activity to be conducted in 10 minutes bouts at least, but currently we have abolished that. We say that any activities count. But this is purely because the technology that we use for measuring activity has significantly improved over time. Back in the days, it was based on survey because people cannot recall any activity shorter than 10 minutes. We have to give them a little bit prompt and ask them to recall bouts that are longer than 10 minutes. These days, everybody wears something like this, or a phone, or accelerometers by scientists. So we can really start to capture movement throughout the day. So now we can look into the fine-grained data. So if anything evolves, it's probably a sign of us knowing the science better. So it's not as confusing. Move more is always good for you. So physical activity guidelines have evolved over time, like I mentioned. Previously, it more comes from the sports field. If you look at the first physical activity guideline that was in the US, that was by a sporting organization. So there was a lot of focuses on vigorous intensity physical activity, on exercise only. But over time, it has really evolved to be all-inclusive. In the recent WHO guidelines, it even includes recommendations for people living with chronic conditions and pregnant women. So it becomes a guideline for everybody, not just the athletes. And I recently published an article analyzing the history of physical activity guidelines in The Lancet. And I'm just sharing this link here in case you're interested in reading about how we have come to where we are today as a field together. And the final take-home message, because I'm here at the WHO Forum, I don't want to just talk about you being active, but how you become the agent for change, how you promote more people to be active. Traditionally, we tend to focus on education, but purely based on an individual approach to make you more fit, personal training. But what we often see is when you remove this type of interventions, even though there was an increase in physical activity initially, the effects often do not sustain. It is because we live in an environment that shapes our behavior. So to promote physical activity in a more sustained way, we really have to action at the system level. So in terms of living in a walkable neighborhood where we don't have to think about physical activity while being active, if the easiest way to get from A to B is always through some sort of physical activity or public transport, people will be less likely to drive. If stairs are more visible in the building, people are less likely to use the elevators. So we really have to rethink about the design at the multiple level of how our environment should be. The International Society of Physical Activity and Health has launched this 8 best investment that work for physical activity. So this is for population level promotion of physical activity. If you take a quick look at this, a lot of that are actually not involving the health sector. So it's really provoking us in terms of working with other sectors, such as education, such as workplaces, such as urban planning and transportation. Because only through this can we achieve creating an active society. WHO has launched a global action plan for physical activity with an ambitious goal of reducing physical inactivity by 15% by 2030. So there is playbook already based on a lot of science in terms of how we create active societies, people, environments, and systems. So take-home messages. Every step counts. The magic pill is so much easier than you think. You don't have to be an athlete. You don't have to sweat. You don't have to do 150 minutes a week if you can't. And improving physical activity is such a good, important investment, not only for the individual, but also for society. And we should really strive for activity-friendly environment. Thank you very much. Feel free to get in touch.
Thank you so much, Professor Melody, for that presentation. I particularly appreciate how you made this whole discourse on physical activity much less intimidating. You don't have to be a sports brand endorser or a super athlete to be physically active. In fact, I kind of want to pick up on, we only have time, unfortunately, for one question and one comment from you. You mentioned the idea of incidental physical activity, which I think is very powerful. Any general advice you can share with people who are listening to us today on how they can design maybe their daily routine, some simple life hacks, as they call it, so that they can be more physically active in their daily routines?
I think it's important first to not feel intimidated, like what you just mentioned. If people come into physical activity with the picture of what I showed earlier of this jogger, then it's very hard not to be discouraged.
Right.
Reframe the question in terms of how much more I can move, maybe not even use the word of physical activity. Then look at your daily routine and see where could be the points that you incorporate some physical activity. For example, think about your weekly shopping to the supermarket rather than driving there every week. Maybe walk there 2-3 times a week and do smaller loads of grocery shopping. Maybe it's like what I mentioned in terms of how you plan your work, plan your travel to work, and think about these time. If you spend 5 extra minutes on the walk, think about the time as investment, because you will get back the 5 minutes, I guarantee you, in a prolonged life. And also at the highest level, be an advocate. If you work for an organization that doesn't have shower and bicycle storage at work, ask for it, because that has often been shown as a barrier. People want to commute actively, but structurally, they're limited in terms of what they can do. So I think we really need to think in terms of our own behavior, but also how we can change the environment for everyone's behavior.
Right. Thank you so much. I think that's such an important mindset that we should carry forward after this conversation. It's really not about exercise. As you said, not about physical activity, maybe even. It's about just moving more, being more conscious of our bodies, our environment, and being an advocate in the different circles or influences we have in our lives. Now, speaking of social innovations, I'm now going to turn it over to my colleague, again, Dr. Sebastian Liber, who is a consultant on healthy aging, working in countries for country support and community interventions, who will talk to us about a new open WHO training and toolkit that will help communities really promote healthy aging. Over to you, Sebastian.
Thank you so much, Jason. Thank you, Melody, for your presentation. It was a pleasure to hear about physical activity and its value. And what I want to present today is actually to tell us a little bit more about what we can do in terms of promoting physical activity and other activities in the community to support a healthy aging. And so for this purpose, I propose to look at 2 key tools that we've been developing at the Healthy Aging Unit here at WHO Regional Office, which is the toolkit and the Open WHO training, as you mentioned, Jason. So here you go. Let's look first at the broader picture. So what can we tell about our societies? They are aging all around the world. So this is a common trend that we can see in many parts of the world. And it presents many opportunities. This is what we think at the Healthy Aging Unit. More participation and engagement for people in later life, but also more years in better health so people can participate for longer. It also represents important challenges that we need to remember about and address in a way to promote this healthy aging. We need to think about supporting people with disabilities and chronic health conditions. We also need to think about addressing important issues of social isolation and mental health in later life. And it is important to realize that we are not all equal in accessing services and support in later life and in terms of our health. And it's important to think about reaching the unreached, people that cannot benefit equally to the health systems and community support. So let's look a bit closer. We see that social isolation, for instance, and loneliness are widespread among older people. This is a UN Healthy Aging Decade report that tells us this. In some countries, up to 1 in 3 older people are lonely, and social isolation and loneliness can have different impacts on older people. They can shorten their lifespan, they can also damage their physical and mental health, and reduce their quality of life in general. So the vision that we promote is a healthier older adults in the Western Pacific region that are thriving and contributing in society. Turning silver into gold is our motto at the Healthy Aging Unit. And for this, we propose to intervene at the level of community, to help people as they age to connect in both healthcare, social activities and services, long-term care, and to access all those services when they need them from the comfort of their home, from being surrounded by their family and their loving one. So it is important for us to try to find support that can help them to achieve this particular vision, that can help us all to achieve this as we age. So what we want to do is to promote community-level coordination and support. The community plays a key role in that. And we think that individual-level coordination is important. We call those coordinations link workers. So those are the people that can help to connect people in later life to social activities and services, long-term care, and healthcare. There are community health workers that we are now trying to train. And this is what we try to achieve, for instance, by developing the toolkit on how to implement social prescribing. This idea of prescribing social activities and community activities for all the people. We will publish this material in May 2022, and we are currently supporting different countries in the Western Pacific to implement this particular kind of interventions. Here we see, for instance, a pilot in Cambodia that we've been doing, which aims at training community health workers to become link workers, to help all the people to connect them between the hospital, their home, and the community. In order to support that further, I have the pleasure of telling you that today we will launch the social prescribing open WHO training that will help community health workers, volunteers, and policymakers to support this kind of interventions across the Western Pacific region and beyond. This is a free 5-hour training, which is available online on openwho.org. Anyone can access it. It is to train health workers and volunteers across the Western Pacific region, and it involves theory, case studies, role plays, videos, documentary video clips, quizzes and resources that will help you to achieve this vision of supporting older adults in the community. Again, this is a free resource. You can access it on your smartphone, computer, or tablet. Go to the openwho.org, type social prescribing, click on enroll. This training will be available later today, so please follow up with us on this matter. So what we want to say is that everyone can help us to move healthy aging forward. You can become a volunteer, you can train using those kind of resources and support your community. You can become a link worker, those specialized community health workers that help to connect all the people with community resources. You can also become an advocate, promoting policies enabling social prescribing and community empowerment. And I hope, and we hope at the Healthy Aging Unit, that these tools will help you to achieve this particular vision of a healthy aging. And now, to finish this presentation, but also to finish our great session of today with Prof. Melody Ding, with Nanai Doren and my friend Jason Liggott, who presented earlier, we will show you different testimonies from across the Western Pacific region that are providing perspective of all the people about later life. What do they think of later life? We also asked them what they felt about the role of community in this particular context in supporting a healthy later life. So let's play this video showing those different perspectives from the Western Pacific.
Next one is drink plenty of water, and like I said before, see your doctor regularly. And all these things are good for your health when you become an old senior citizen in Colonia or in Bondi. So be nice to yourself, take care of it, and you can live up to about maybe 100 years old.
In order to make people more happy and healthy, I think the community should provide some different fitness equipment in indoor or outdoor places. Besides this, the community can organize some different entertainment every year.
Oh, I would like to see many things, but still want to contribute whatever I can do for the health of people, for the development, for helping the young generation to get more knowledge, experience what I gain for my time. So that also I would like to see. I also would like to try to do more sport and relax during the weekend, coffee with family, with friends, in the free time. That could be beautiful moment for me to enjoy.
Thank you very much. And I love all the senior citizens going.
So thank you very much, everyone, for taking part today in this presentation on healthy aging and this session on healthy aging and support in later life. It's been a pleasure to be here with you. Thank you so much to our participants, Melody, Nanai Doren, and also thank you to all the people that sent their videos that you could see right now for having participated. So I will leave it here and wish you a very nice day. Maybe Jason, you would like to say a final word as well.
No, just to say thank you, of course, to everyone for joining us today. And I think even though we were unable to speak with Nanay Doren herself during this session, we can really all take inspiration from her and what she's doing later on in life. Clearly, physical activity is for everyone, everywhere, at every time. So on that note, thank you again for joining us, and back to you. Thank you.
Thank you, Sebastian. Thank you, Jason. Thank you to all who have participated in the social prescribing session. And indeed, I think we all still have ringing in our ears the lovely voice of Anna Smert, and we promise to bring her back tomorrow at this lunch break. Forgive me, at the lunch break session, where she will give us a bit more of inspiration as well as entertainment. We launch now into the third problem-solving session, where our colleague Sharon Salmon, Technical Officer with the WHO WIPRO World Health Emergency Division, will convene and moderate a session on increasing digital application adoption. Over to you.
Thanks very much, Dr. Gowden, and I echo you to be able to say that it was fantastic to be able to hear Anna play and entertain us for that break, and also to hear about the physical activity exercises, which we look forward to tomorrow. It's my pleasure to be able to moderate this third problem-solving session. And as a way of introduction, I have a panel of fantastic experts, 8 experts across the region, to be able to join me for this session. And I'd like to start off by allowing each one of them to be able to introduce themselves as we go into this session. So by alphabetical order, I'll just read out and ask for panelists to be able to turn on their cameras and to be able to introduce themselves. Firstly, turning to Mr. Jeremiah Calderon. Over to you, Jeremiah. Just checking if you're connected, Jeremiah. Just checking your audio. Excellent, we can see you now, Jeremiah. You'll just have to unmute yourself and then you're ready to go. Thanks, Jeremiah. If you could just introduce yourself. Thank you. Maybe what we'll do is we'll go to the next person and we'll come back to you, Jeremiah. You seem to have just some audio issues. We'll come back to you at the end, and hopefully we'll sort out those technical issues. This is something that normally happens with any sort of IT and virtual settings, so no stress there. Professor Meng Chung Gong, over to you.
Hi, nice to meet you. Could you see me?
I can.
You hear me?
I can hear you clearly.
Thank you.
Hi, nice to see you again.
Hello, everyone. I'm Meng Chun. I came from Southern Medical University of China. We share some experience in digital innovation during the COVID-19 for the community-based syndromic surveillance. So it's very happy to join the Innovation Forum, and welcome to join discussion, and thank you.
Thanks for your introduction. I'll now hand to Professor Raina McIntyre. Raina, over to you.
Hello, nice to meet everyone. I'm Raina McIntyre, public health physician and epidemiologist from the University of New South Wales, Kirby Institute, and interested in surveillance and digital methods for public health surveillance.
Thanks very much for your introduction. Over to you, Lei Motila.
Hello, everyone. I'm Lei Mutilia from the Philippines. I'm the co-founder and social innovation lead for AI for Golf. Our innovation team has worked with the Department of Health in the COVID-19 response, and our innovation is one of those that scaled to 1 million. So we're very happy to be here today.
Great to see you again. Thanks very much, Lei. And to Dr. Michael Noonan. Michael, over to you.
Hi everyone. Well, I'm Michael from Beyond Essential Systems. We support and implement a number of softwares focused on the Pacific Islands, countries and territories, but also in a couple of other places. So mainly Tamanu, Tupaia, and Supply and DHIS2 implementations. Based down in cold and very windy Melbourne today, but yeah, really nice to see everyone.
Yeah, nice to see you as well, Michael, sending you the sunshine from Manila. Over to now to Dr. Desi Baharaja.
Hi everyone, hi Sharon. I'm Desi, a public health physician. Worked in the Ministry of Health of Malaysia for about 12 years. I'm based in Kuala Lumpur, Malaysia today. Some of the work that we have done is with Viva Rio during the Rio Olympics to predict dengue and Zika outbreaks with RITM, Research Institute of Tropical Medicine, Manila. As well, today I'm with the private sector as the Chief Medical Innovation Officer looking into the whole spectrum of digital health. Thanks, Sharon.
Great to see you again, Desi. Thanks very much. And over to Professor Torsten Sierman.
Hi, Sharon, and hi, everyone. My name's Torsten. I'm the head of bioinformatics at the Doherty Institute Public Health Laboratory, and I've mainly been involved in using genomics to do surveillance of pathogens, both viral and bacterial, and outbreak investigations, and obviously been very busy rolling out AusTracker, which is a national surveillance system for, that we use in Australia. Thank you.
Thanks for your time to join us, Torsten. And to Ms. Shanae Sui.
Thank you, Sharon. Hello, my name is Chande Sui. I'm a managing director of Instead iLab Southeast Asia, and I'm calling from Phnom Penh, Cambodia now. And we have been collaborating with the Ministry of Health in Cambodia in designing and rolling out the public participatory surveillance tool, which I will share shortly as well. Soon. Thank you.
Shanae, pleasure to see you again. And I'll come back to Jeremiah Calderon. Just checking that your audio is okay now, Jeremiah.
Yes, I'm Jeremiah from FHI 360. I work in a USAID project addressing tuberculosis. I'm based in Manila, Philippines. Thank you.
Great, thanks very much. It's a pleasure to have 8 of these experts to be able to join us, and we have had discussions previous to this to really talk about the different aspects to problem solving and how we can actually take this session forward. To present the problem statement, I have Davison Tay, who is a consultant working at the WHO Country Office Philippines, to be able to give us a very short presentation on the issues and presenting us with the problem statement so that we can then ask the panel to be able to comment on that on ways forward. Of course, we're thinking about scaling for impact. So with that, I'd like to hand over to Dave for his presentation. Dave, are you there?
Yes, good afternoon, everyone. My name is Dave, Davidson Tay, you can call me Dave for short. I'm from the WHO Philippines Country Office, and let me provide you a brief presentation regarding the NTB App Suite, and of course, as mentioned by Sharon, the gaps and challenges that we are encountering. Let me just share my screen. Confirming if you can see my screen.
Yep, that's great. We're just waiting for it to, I think, click over.
Is it there?
Thanks, Dave. Yep.
Okay. Let me begin. So Last year, the Philippine Department of Health, supported by the World Health Organization, has launched a comprehensive and multi-stakeholder NTB app suite, which aims to provide a complete digital solution for TB in the country. More so, it aims to support the government in reaching its planned TB elimination targets and provide an innovative solution, of course, during this time of the pandemic. One great thing about this app suite is, I mentioned it's a complete digital solution. More so is that this app suite is integrated within the national TB information system of the country. What does that mean? It means is that the apps within the app suite is able to push and pull data within that TB registry system, so that it allows for real-time reporting and also real-time registering of patients, among others. So allow me to just go through with each of the apps. So as mentioned, it's a set of apps. So we have the Raise TB app that supports surveillance and monitoring activities with real-time dashboards. The target users of this Raise TB app are program managers and decision makers. We also have the Care TB app, which is meant for patients and contacts to check their e-records, do self-screening, connect with providers, and find nearby facilities, among others. It is also meant for health providers to implement the TB care cascade. Thirdly, we have the Guide TB app, which is specifically focused on e-learning for health workers. Also, it acts as an important reference with all the major documents that is easily accessible in the palm of your hands. And lastly, we have the Lead TB, which is used for programmatic management and supervision, including remote supervision. And this is meant for the providers and supervisors. Now, the thing is, as I mentioned, it was launched last year, but the gaps and the challenges that we are encountering is first is that, again, the digital solutions are there. The awareness of these tools are high, but within the central within the central level. And it is much less at the grassroots, probably amidst the various promotional materials that has been probably because of the emphasis given to the COVID-19 efforts in the past year. So we actually made a lot of social media and promotional campaigns for the NTB app suite. However, it seems to be not that effective. So the main problem right now, the main challenge that we are facing is that the uptake of these apps has been limited, and most of the users are TB implementing partners and projects. And again, the intended users of these apps really are those are the government and of course our health workers on the ground, both for the public and the private sector. So hopefully that was clear. That's all from my end. Thank you very much.
Dave, thanks very much for that succinct presentation. And as I've mentioned, we have had discussions around this problem statement, and what we've gathered from it is that to be able to scale it for impact, to be able to get people to use the applications that seem necessary, that have got encompassing a whole lot of different aspects for TB care, we need to be able to dig a little bit deeper into it and see three specific things that we categorize it in. How can we get people to use it more? How can we get the processes in place so that it's connected, so that people are finding it easier to use? And then also, how do we enable it? How are we able to make sure that these applications can be used by people no matter where they are located? So breaking up our problem session into these three categories: people, process, and enabler. I've divided up the panel to be able to share their experiences and to be able to give some insights on how we can give some recommendations, or to think about possible solutions for scaling up this particular TB app, and using the panelists' experience to be able to share how to be able to do this. So for the first section, which is about the people, without people using it, the app is essentially useless. So we need to be able to reach the people properly. The question is, how can we better understand the facilitators and barriers to improve engagement of application users? And I'd like to turn firstly to Menchun to be able to share his experience and on his recommendations on how to be able to improve engagement. Menchun, over to you.
Thank you, President. And thank you for our Philippine friends to share their platform and the challenges. Actually, the usage and uptake of the new technology and solutions are a general problem. So this is not unique for this solution. So our experience, for example, what we did, it's kind of similar, which is syndromes reporting and disease surveillance and some clinical care support. I can give some not really guidance, but kind of suggestion is the first would be what can the patients or the users get from the app? I mean, can we provide some artificial intelligence or clinical decision support information for their daily care? I mean, it wouldn't be like clinical level, but some like education or compliance or some daily information for those patients. This is first what we need to consider. The second would be a kind of similar suggestion, but it's about interaction or be more interactive. So the patient needs to get some specific targeted information or suggestion to himself, not like very general. Like, for example, if a patient with high risk of cardiovascular disease is not obese, diabetic, we should not like send messages about type 2 diabetes to him or her, because that will make him like feel this software or solution is not specific for him. So be more interactive is the second recommendation. And the third would be the privacy protection. So for example, because tuberculosis, similar like other transmissible disease, privacy protection of the users is a concern, not only of the government, of the developer, of the clinical side, but also very importantly of the users themselves. So we have to be very clear on the privacy protection technology implementation and also our policy, our rules. That will help our users to relieve, not be so concerned with this, and that will definitely increase the usage and uptake. So these are three recommendations, and generally they are general suggestion, and we would. It's a privilege to have this discussion, and I'm very happy to provide further discussion and suggestions. And thank you very much, President.
Thanks very much, Menchun. It was great for you to be able to list those recommendations. I'll now hand over to Lei, who will also give her recommendations and solutions to this problem. Hi, Lei, back over to you.
Hi, thanks. Sharon, can you see my screen?
Yep, it's perfect. Thanks very much.
Thank you. So I would like to approach this problem statement looking at three levels. So first, we start with the end user, the process of adoption, and the organizational context by which this adoption for scaling is going to happen. So first, let us start with the end user in mind. So we mentioned in the problem that there's a limitation in terms of the ability to engage. So with this, we first start with an empathy map. So what might the user feel, see? What do they use? What do they hear? Which information channels are they being influenced by? And with this, I first want to ask a question. If I'm the end user, maybe we can empathize first. Is the user being engaged in a channel that they are already using? So this is contrast with, am I asking the user to download a mobile application? Am I asking the user to go to a link that is not easy to access? So for AI for Golf, for example, this is the first thing that we did. We asked, what is the channel? And for the Philippines, we have proven data that 65 million Filipinos and more than the voting population is monthly engaged in a messenger application. So therefore, that's why, in our experience, that is the channel of choice. The next thing is, as the end user, am I inspired by what I'm seeing and experiencing? So if I'm using an application, yes, I see information, I see a dashboard, I see some information, but am I inspired? Is this moving me to action? Or am I feeling cold? Am I chilled by this thing that I'm seeing? Because maybe it's not triggering my motivations as an end user. So this first slide is a way to maybe empathize with the end user to answer the question, why is there a limitation in the number of engagement? So for a contrast for our innovation is when Kira launched, it was very easy for users to adopt it. So that's why right now it's 1.3 million with 35 million interactions. So when you have the right channel, it is much easier to have the users get it because the transaction cost is much less than whether you have to download an app or go to a website. The next one is the process of adoption. And with this one, maybe it's unrecognized, but the question here is the vendor engaged, transactional, or transformational? And during the COVID response, this is one of the key things. There are many vendors, there are many IT managed services, and even for the NTB app, is the hired vendor, the chosen vendor, are they transactional or transformational? Because the process of adoption is very complex. The political, organizational, financial, technological, it's really complex. And as a vendor, if you have chosen a vendor that is very limited with their terms of reference, it is much harder for that vendor to adopt to the evolving changes very quickly and very fast so that they can always respond to the need of your end users for adoption, may it be in the provider level or the public level. And then lastly, for the organizational context, are the people inside, from the regional to the local level of the health ministries equipped to facilitate scale? So let's say you have a great application, you have a great vendor, but is there data culture in the organization? Let's say the Department of Health, is there design literacy that people are not just are aware that it's of the importance of user experience in the process of adoption? Because if it's not so, then this becomes a barrier to help in championing the right kind of language, right kind of communication or social marketing for such an application to be widely adopted. Thank you.
Thank you very much, Lei, for your insights. Incredibly succinct, and there's a lot to be able to consider when looking at how to be able to increase the user uptake. Let's now cross to Michael Noonan. Michael, are you there? Over to you for your intervention.
Thank you. I'll just get my share screen working.
Sure.
Should have had that better already. So yeah, I was asked to address the question: how do we better understand facilitators and barriers? And not wanting to focus too much on our software, I really narrowed it down to 3 things that we try to use as principles across all challenges that we face. And I don't want to apply them too specifically to the challenge question because I don't know. We don't work in the Philippines. We don't know the context, and in particular on our second point. Context matters a lot, but I think one thing that's really, really important is to get boots on the ground, or at least get boots nearby. You can have the greatest software in the world, but if your support team is 15,000 kilometers away, it doesn't work. Particularly in the contexts that we work in, which are lower population, highly isolated and remote countries. Getting engagement from a support team that might be based in Europe is just not feasible, and people lose faith in it really, really quickly because they don't feel that that there's ownership, if you like, and it's quick responsiveness that gives local ownership. Perfection is the enemy of good. We say this nearly every day with us. Now, I really, really want to stress I'm not having a go at the app suite that's been presented in the challenge question, although I did warn Sharon and Jeremy I might not be invited back to speak at a WHO forum after this. But setting out you should always ask the question, do we need a 4-app suite for every single clinical use case? Now, as I say, possibly in the Philippines, that's perfectly fine because the population is massive, and there's assumedly a lot of people that are working specifically on the TB program. In the context that we work, though, health workers are wearing multiple hats. The same health worker that's doing TB management and treatment is also doing NCD screening. They're also doing antenatal care. They're also doing, acute care at the primary healthcare level. And having a 4-app suite for a single use case or a single clinical area could quickly spiral into having literally 80 to 120 apps over the 20 or 30 clinical areas that they're dealing with in any given week. So can existing tools be repurposed? Is there an existing tool that's really, really successful in the country or in the context that you're working in that can be repurposed, that has perhaps 80 or 90% of the functionality that you're looking for? We often go into projects where the stakeholders, the donors or a particular consultant on the project has very, very specific requirements. And I don't want to point to any recent examples to avoid getting myself into trouble, but often it's the last 10 or 20% of functionality that an existing app or an existing software solution ends up stumbling on. And so there's this need. We need this other app. We need this very, very specific thing. It has 100% of the functionality that we want. Our response in that case would be perfection is the enemy of good. Introducing new apps and new suites of apps is extremely difficult. So if you can repurpose something that's already working effectively, that can be good, even if it doesn't have every single feature that you need. And the example we point to is very self-serving, but in Samoa recently, we were using our Tamanu mobile app for COVID-19 vaccinations and for NCD screening. They came to us and wanted to use a module within it that does COVID laboratory testing and rapid test recording. Now, was it originally designed for that? No, but they were able to be using our module for that within 48 hours of the request being made. And it's been very, very successful since then. Could you create a better app that does those two functionalities? Probably, but could you introduce it? Probably not. And in that, remember that there's always going to be something you can't do, even if you introduce a new app. And 2, you can't please everyone. So don't beat yourself up for 75% of the time trying to meet 100% of the functionality. And the third thing that we talk about a lot is fail fast. So don't spend 2 years trying to design the absolute perfect program and the perfect solution with a huge implementation and everything, bells and whistles going off 2 years down the track. You're just as likely to get things wrong after 2 years as you are after 6 months. I'm not saying that we should do pilots after pilot after pilot, but that doesn't mean that you can't field test really, really rapidly and iterate something, so that if you've got a 2 or 3 year project, get something into the field in the first 6 months and be iterating, adapting, applying the agile methodologies that we use in software development to your project management and to your project and software design, so that you end up with something that's really, really fit for purpose after 2 years. The fear is that people will lose faith with it because you launch something that's not absolutely right. We would counter that by saying they may lose faith after 2 years and you've lost all of that time, and that having them see the iterations gives you a better chance of local ownership on the ground. They feel like it's something that they have created and have a stake in. And we really like that concept of failing fast. And if it's not going to work for like really fundamental reasons, far better to find that out after 6 or 8 months than to find it out after 2 years and a multi-million-dollar implementation. So those are my 3 things. I don't know necessarily that they relate to the problem statement, but I think that they can be applied fairly generally to understanding facilitators and barriers and making sure that we're being as efficient as possible.
Yeah, thanks very much, Michael. I think that you will be invited back for other session. I think this is the second time that you brought this up with me, but absolutely what you're bringing is a perspective from a different lens and having a look at a problem and then looking at all different possibilities for solutions forward. So I think, I appreciate your insights and actually your practical approaches to how to be able to look at this particular problem, especially with being able to leverage on other existing apps, so you don't have to keep reproducing, or you can gain the strengths from other apps as well. I guess that brings us to the end of this sort of like question. We're talking about people and how to be able to engage people a lot better. And if I was to summarize this particular discussion from our fantastic 3 expert panelists, it's keeping it end user centric, so that the end user has to be at the core of how this app is developed and how that they can actually utilize it. And the second part would be triggering people to be able to use it and encouraging the interaction. Without this, then people aren't going to use it, and it's another app that will just be slowly die out, and no one will be able to use it. So having that interaction and encouraging people to be able to use it. Context specific came up on all 3, and making sure that you understand the context on how you're putting out these applications and making sure it's relevant for the people that should be using it. And the third part, coming back to Michael's point, is about leveraging on other apps. It doesn't necessarily mean that you have to create something new, but seeing what is there and what can be harnessed on or repurposed, as Michael had said, for this particular purpose, which is for TB care. Now, if we go to the second part, which we're looking at is processes, what should we consider and how do we integrate the application into standard operating practices for healthcare workers? So we know that we've looked at the people, how do we encourage the people to be able to use the app, but what are the processes that are able to be put in place or have to be considered to make sure that people are able to use this application? I'm going to turn first to Jeremiah for his interventions. Jeremiah, over to you.
Okay, thank you. So just to provide a brief context, I previously worked as a doctor to the barrio in an off-the-grid municipality in Samar province in the Philippines. And having worked at the grassroots, I understand the low uptake of users because of less awareness in the ground, since we have been used to the top-down style of governance. And the creation of the app is an important milestone in streamlining data collection. It is linked with the integrated TB information systems. And however, TB data recording and reporting remains to be an issue. And needless to say, health information system is integral in health governance and TB modeling. And I noted that the Care TB app incorporated important function of customization at the local context. And the role of civil society organization can be tapped here. And CSOs can be tapped to be, because they are more connected at the grassroots level and even down to the household. So they can be useful for the healthcare providers in case they have problems in data collection, etc. So to show how let me point out the 3 issues that I saw in the problem statement earlier. So maybe I can request Puishan or someone to share the slide to integrate all these 3. But let me point out the 3 issues that were based on the problem earlier. First was the mobility. And last year, when in 2020, when COVID-19 broke out in the Philippines, and because of the strict COVID lockdown, we were able to pilot telecontact investigation. And this is the facility's way of reaching out at the household level to screen for, to find missing TB cases and to identify at-risk households for eligible for TPT or TB preventive treatment. And using this strategy, we were able to screen and identify 152 household contacts and 21 active TB disease and 85 who are eligible for TPT. And to institutionalize this, the USA TB Innovations Project worked with the DOH to develop a field implementation guide for healthcare providers. And second, the low uptake of the RAISE or LEAD TB app can be probably due to the low appreciation of the government leaders in terms of data for programmatic management. So the COVID pandemic provided an opportunity for the national leaders to use mathematical models in COVID decision making. So I hope that this could also be used for TB modeling in tuberculosis control program. And aside from its ability to predict the trends, it can be used for cost-effective analysis, which is more relatable to our elected leaders. And however, in order to develop this robust TB model, it it goes back to the development of reliable TB data recording and reporting. So my third issue that I want to bring up is in governance. And I have worked in different healthcare settings in the Philippines. And over the years, I have seen how the communities can be can be treated as partners instead of mere recipients of health services. So this can be done through the participatory governance approach, and community participation will ensure that that their needs are reflected in the government's action plan for health. So integrate all of this. That's the innovation solution that I'm proposing, that I have proposed in this challenge. Thank you. I think you're muted. I can't hear anything.
Sharon, I think you're muted. Yeah.
Somehow electronically I was muted. Maybe the computer had enough. Yeah, so Jeremiah.
We can hear you, Sharon. Go ahead, please.
Absolutely. Yeah, there was just some technical issues on this side, no problem at all. Jeremiah, I just wanted to check if you wanted to show any of those slides at all, or you just spoke to those.
Yeah, I just spoke through those, but the slides will just supplement what I said earlier to integrate all the three I mentioned.
Jeremiah, I really appreciate your insights, and especially about involving other organizations like the CSOs or the civil society organizations to be able to help to roll out some of these processes with the apps. Thanks, Jeremiah. I'll now hand over to Desi. Desi, over to you for your intervention.
Yeah, thanks, Sharon. So I think when it comes to processes to integrate applications to healthcare workers is one of the most challenging things. We have also seen that in the curative space, basically putting EMR into hospitals, governments trying to achieve lifetime health record has always been challenging. So now when it comes to surveillance of public health, even for this in particular, in this focus, TB, I think fundamentally we need to understand that healthcare workers are perpetually overwhelmed, even without COVID. So we got to keep it very simple in terms of getting an application to the ground or to the healthcare workers. Secondly, there are differentials in upticks across demographies and regions of healthcare workers. We clearly see that it's very different from the Middle East to the Southeast Asians, or even to North America and South America as well. And thirdly, Sharon, even studies have shown that slow load times of bandwidth, basically 10 seconds, it's all it takes that to demotivate a healthcare worker from actually keying in data or using the data or using the application. So these are practically very important problems that I see globally. Now, in terms of suggestion moving forward, Sharon, I would like to propose 4 different suggestions. So the first thing is a potential solution is to qualitatively assess the barriers to entry among healthcare workers. So basically, it's not creating the app and then pushing down to the healthcare workers, but it's qualitatively assessing the whole barriers together with the healthcare workers. The second point, Sharon, will be value propositions must be sufficiently enticing to healthcare workers as well. So these propositions should show not only the patient benefit, but also the potential for the application to lighten their workload with minimal added complexity, while also allowing for tangible improvements in their work outcomes. I think that's very important. So in other words, if necessity is the mother of invention, they say simplicity is the father. So I think that's very important. The third point here is user interface, I would say. So it is critical to keep systems, whatever application in healthcare for this, of course, TB, it is critical to keep system as simple as possible, even when they are irreducibly complex. I think it's very important. So for an example, Apple does this fantastically by, allowing even technology naive individuals to access supercomputers in their pocket, which is our iPhone today. And finally, incentivize first, Sharon, and enforce later. I believe in that. As we can see during the Obamacare, where there is something called the meaningful use of data, whereby physicians are actually incentivized for keying in data in EMR in order to get faster turnaround time of reimbursement of insurance, more budget for hospitals. So there's an important component to incentivize first and enforce later as well. All these 4 points are actually pertinent in order for us to gain the trust and also the support from the healthcare workers, because without having them, usually it breaks the whole chain or the whole spectrum of what we are trying to do in whether it's curative space or preventive or predictive. Finally, in a nutshell, Sharon, I believe resistance exists in all disruptions. When the value becomes apparent, adoption will naturally come. So I feel that we should just stay the course. Thanks, Sharon.
Thanks very much, Desi. And I know that you have a wealth of experience. So you've summarized it really, really well within just a couple of minutes. And I'd like to thank yourself and Jeremiah for tackling those process questions, because without linking it within the process, then it becomes something that you can't actually use. And bringing it back to your point, Desi, that healthcare workers are overwhelmed. There is a lot of different applications. The more that we go to paperless systems within many of our healthcare facilities and health systems around the world, adding apps onto existing systems can be quite overwhelming with such a high workload for healthcare workers at the front line as well. I guess in summary, from both of your comments, what I'm hearing is that we need to be able to work with the organizations. We need to actually outreach further than the organizations, but those that can support, like civil society organizations. But assessing the barriers, as you mentioned, Desi, is pertinent. A qualitative assessment to be able to understand where those barriers are, to address them properly. And the value proposition, as you mentioned, if healthcare workers are seeing the value in reducing workload, it is more likely that they would want to be able to use those applications that are friendly, that are interactive, and hopefully with some sort of an incentive to, again, make users more wanting to use these applications. So again, thanks to yourself, Desi, and to Jeremiah for your inputs. It's a nice segue when we're talking about, Desi had mentioned about slow bandwidth. Let's now think about how do we enable the processes so that applications can be a little bit more accessible. And again, with the thoughts behind this whole innovation forum, which is about scaling for impact as well. So the question is, how can we make the application accessible to all? Thinking about remote communities, thinking about perhaps people that don't have smartphones, no data packages, little to no reception for these applications to be used. To address these questions, I'd like to firstly ask Shanae for her comments. Shanae, over to you.
Thank you, Sharon. Let me share my screen. Yeah. So thank you, Sharon. So I'm gonna walk through perhaps the intervention that we do in Cambodia, and I'm hoping that this is gonna be shed some light, also some possibility as well for the Care TV app for the Philippines. So for Cambodia, we're looking at for the question, how can we make the app accessible to all? So basically, for Cambodia part, what we work with the Ministry of Health in Cambodia, we're looking at identify the keys in here is identified to accessibility for people to participate in disease surveillance. Number two is to how might we leverage or designing the technology solution that can reduce the work burden of the health worker in an ongoing basis of the routine of the reporting. And the third thing also, like how might we making the also text also to be more like flexible. So we basically, the way we do it, similar to our keynote, our speakers earlier, is we're looking at what exists out there. Number one is, what is the pain point? What's the real need? And then what exists out there, like infrastructure-wise, system solution-wise. So we reuse the infrastructure of the hotline from a small scale, and we're looking at this solution, which is the scaling up nationwide, and reducing the open source tool as well for the solution itself. So basically here is while we're looking at the public participatory, the question is accessible to all. So basically, our solutions for the case in Cambodia participatory hotline, we designing the solution for the end user as a low tech. So anyone who have access to basic mobile phone, that they can use it for voice call is enough. So they can basically be using that when people dial in to the solution that we have, the hotline, the system will detect whether this is from the health worker or is it from general public. And the line basically is a toll-free. It's a free for public access, free for health worker to report. So basically using the basic low-tech tool, designing it for the all public to use for reporting disease and also for the health worker. So I'm gonna going quick to here. Yeah, and a part also like the accessibility, because of healthcare worker is for the low resource country like Cambodia is they wear multiple hats and small number of like workforce. So here we're looking at how might we use designing the technologies to make it reduce their work burden and more as an empowering them rather than demanding more of their time. So for the solution itself, when we're looking at the technology, we need to be also the technology that enable the flexibility in times of the situation. For our case of the hotline, it have multiple role as like a data collection as a routine from health worker, reporting from general public, and during the time of COVID, it's customizing in a very short period of time to support the contact tracing that connected to the WHO Go data and supporting the workforce of like several people that doing the manual one to send out millions of contact tracing calls during the COVID. So I'm just quickly showing that. So as an example of like technology enabler for the accessibility, we can see that like for the case of like the one in Cambodia, the blue line here is the call to the public hotline, the daily call. So during the COVID, there was a time that it's close to 20,000 calls per day reached. And you see the red line here is the COVID cases in the country. So you can see how the public participated and how is the case, real case happening. So in summarize, so for the solutions that were designed, we use for our intervention, if you're looking at like 17 million of the Cambodian population for the period of from 2016 to 2022, the result is 2.5 million of the public participating in calling to learn about new disease, to report about cases. And out of that, just during the COVID period alone, for the contact tracing, 1.2 million plus actually, automatic call using the hotline has been supporting the contact tracing team. So instead of like dialing one by one, this hotline had to send automated contact tracing call to the populations. And among 1.2 million that call out, only 1.3% out of that they confirm the symptom and that require the human attention to make a call to further follow up. So we're looking in here is looking at technology enabler for accessible to all. I want to say that it's designed right with all the methodology that all our speakers mentioned all before, like human-centered design, be agile, and it actually really help the health workforce and the disease monitoring. And I can say that our case in Cambodia, with the data, it's proven that. So here's some of our recommendations properly. So for the case of TB care, I think probably I think it's very difficult to say because quite depend on the country context. But I would believe that the public participatory is really necessary and for the preparedness and for monitoring and responding to any of the pandemic or even the specific disease like TB. And if we are also looking at the access for all, then of course, I think probably we may need to looking at the low-tech non-smartphone user. So that's what inclusive need to become in. And another thing is there is the principle, the principle for digital development, very putting out, like actually if you search on Google, the principle for digital development, the recommendations, several points for any of the technology solution design should be following that, to making sure that solution is inclusive, to making sure that the solution is properly designed for scale. And another thing is for recommendation for the sustainability is giving this as from our experience only, as for the solution to be sustainable, it needs to be from the beginning at the design, even before the pilot, work closely with the partner that who will take it. For example, the Ministry of Health. And that also solution need to be also fully managed and operate by the ministry. And for the low resource setting country, one thing is about that when we talk about technology, it needs to be also making sure that there is local tech in country that have the capacity for the support and maintaining the solution. Because that is when it comes to in terms of like beyond the pilot, when we're talking about scaling solutions, and that's really needed the resources in country to making sure that the solution is continue properly maintain and support the stakeholder. Thank you.
Very much, Shanae, and I know that your project is absolutely testimony to the fact that when you have the right solutions, then you can actually reach millions of people, which really does show the scale of low-tech solutions. We've got about 5 minutes left to the hour where we have to be able to close on time, but I'd like to be able to now turn the floor to Raina McIntyre. Over to you, Raina.
Thanks, Sharon. So it's been really interesting to listen to everyone's input. The innovation that we developed is EpiWatch, which is an open source early warning system for serious epidemics. So it's more of a public health tool than a patient clinical tool. But I guess, my thoughts are that there's a few different aspects. Before we even designed or developed the system, we had extensive stakeholder engagement and discussed with our potential users what their needs were, how they were getting their epidemic intelligence currently, what were the gaps, so that we went into it understanding what people wanted and what their needs were. In terms of the TB app, I guess it's both patients and providers if you want to utilize some of it for surveillance. And I think it's also really important to have continual input from users to continually improve the products and not think of them as static, but things that can continually improve based on not just user input, but differing circumstances and external factors. I think the idea of open access and open source is also good, because the more widely tools are accessible, then the more they can be used. In terms of remote and rural areas where power supply may not be certain or consistent, having options for solar powered charging stations for mobile phones, for example, will improve the usability of some of these tools. Language is the other really important one, which we found in that certainly for epidemic surveillance. So we do our searching in 40 different languages, including every major language of Asia. And then I guess privacy and stigma when it comes to a patient app are the things that need to be addressed. And that could go back to user input and user feedback. So we are, giving flexibility in the tool. So we have both a web-based application as well as a mobile application, so people can choose whatever suits them the best. And because it's more of a public health tool, we also have like a decision theatre to allow interactive engagement with the tools rather than just a one-way interaction. So I might stop there.
Thanks very much, Raina. I know that you're probably looking at the time as well. So I appreciate that. And I appreciate actually you're echoing a lot that Shanae had said as well in terms of the flexibility and around the tool. And again, putting it back to the people as well, what sort of user interface is more applicable for them. I'd like to turn to Torsten for his comments.
Yep, I know we don't have much time, and I'm quite happy to say that a lot of what I wanted to say has been covered by the previous speakers. So it's good to see that we're all kind of on a similar wavelength. One thing I'd like to, I'll just say one comment, and that is around apps and users. And it's kind of been alluded to, but users get annoyed very quickly. If your app doesn't work the first time and they have that first bad experience, that it's very hard to attract them back to try again. So you want to make that first experience as good as possible. And one way to do this is, like we've said, is to keep things simple, so that less bugs can happen. Like if you think of what is the most popular app in the world, it's probably Google, and Google has one search box and used to have two buttons, I'm feeling lucky and search, and now it just has one button. So it's kind of as simple as it can get, and it kind of is inversely, its simplicity is correlated with its usage, I would say. So what I think it's important to get what I would call champions in the testing phase of the software. So champions from the healthcare worker side, from the consumer or patient side, people who are willing to sort of put up with some bugs and give you feedback. And then, as Dr. Newman said, like to rapidly get that feedback fixed. So you get the app fixed really quickly within 24 to 48 hours. You want these bugs fixed before they start annoying other new users. That's all I kind of really wanted to say. Thank you.
I appreciate your comments. Thanks very much, Torsten, and to Shanae, Raina, and yourself for being able to talk through some of the enabling factors for apps. It's just 1 minute past the hour, and as much as I'd like to be able to invite Dave back for any final comments, I'll close the session here. And I know that we'll have a summary session later this afternoon, Manila time, but it's been my pleasure to be able to moderate this session, and I hope that all of you have found this incredibly useful, as I have. And thank you very much to each of the 8 expert panelists that have joined this discussion for your time and energy and expertise. So back over to you, Dr. Gowden.
Thank you, Gordon, please. So thank you, Sharon, and thank you, Davison, for the moderation and the problem statement. Thank you to the innovators for their multiple views on adoption of digital health applications, which are becoming more and more prevalent. Indeed, as you stated, sometimes maybe one of the barriers to adoption is that they are too prevalent, and there are too many of them. So you have summarized so well the principles of a good app. And I think the report of this forum will be much enhanced by both the problem statement and by the rules that you have put forward from your experience. As we talk about scaling for impact, it's almost a case that if you can't scale in the area of digital health, then you won't be able to scale anywhere in public health. And so the digital health is a test case for the ability of a country to deploy and to achieve impact at population levels. So thank you so much. This time we will observe the agenda and give people a physical break. So shall we move straight into the mobility, the mobility break? For those who are not Wipro staff, please know that there is a Wipro dance company who very kindly make little demonstration videos for our governance and technical meetings. so that people get a chance to do some physical